Hey guys, are you able to see and hear me? Yes, thank you very much for your confirmation. Yeah, I can see a lot of students who are attending the session right now. So no problem at all. Yeah, hi guys. Hi everyone. Hi everyone. So I've named this sessions as extra advantage sessions in medicine. So Swapnil, I think we have already uploaded the unannotated PDF in the Telegram group, so you can download it and you can take notes on it if you want to. Otherwise, the annotated PDF will be uploaded in the app. So no need to worry about that. Yeah, so I was talking about the extra advantage session. So I'm going to do somewhere around like 12 to 13 sessions. So on various topics that are kind of overlap areas. So I thought valvular heart is something that we can do as an in-app session, probably because this is a kind of area that we have to discuss with the students. So because it's a clinical topic, that's the reason. Yeah, there are some infectious disease topics that are going to be done in the live sessions, like for example, HIV/AIDS, then tuberculosis, then the syndromic infections, like the UTI, infective endocarditis, meningitis, pulmonary infections. So there are some syndromic infections, so that has to be dealt separately. So those things also will be done as live sessions, and it will be uploaded in the app, so no need to worry about that. Yes, we are going to schedule the sessions. The only thing that is bothering right now is the other sessions that are going on. So I have to be like very sure that it doesn't overlap with the other sessions. For example, the NEAT next sessions. So we have to see a lot of other things also. So don't worry about that. And we'll take care of the headache. So somehow, like I'm planning to give around like 12 to 13 sessions at least, and it will cover almost everything, all the overlap topics that whatever is required and essential. So fine, all right. So let us move on to the sessions. Today's session is going to be on valvular heart diseases. All right. So let me begin the session. So first, we need to talk something about rheumatic fever. So that is acute rheumatic fever. So you all know for diagnosing rheumatic fever, you're going to use something called as Jones criteria. This is also referred to as something called as Duckett-Jones criteria. And they have modified several times based on the needs of low risk as well as high risk population. But can you tell me, so what is the main pathophysiology behind the development of acute rheumatic fever? What is the main pathophysiology? Everyone can answer if you want to. So what is the major pathophysiologic mechanism? So it is called as molecular mimicry. Right, correct. I can see a lot of answers. Okay, it is because of molecular mimicry. That's the most important mechanism. And what is the most important antigen, by the way? So you told it's molecular mimicry, right? So what is the most important antigen? There are a lot of antigens, but what is the most important antigen? Not really. It's a carbohydrate antigen on Streptococcus. That is a specific antigen. It's M protein. M protein is a broad term. I need a very specific antigen. Again, it's a straight line from Harrison. The most important antigen is going to be NABG. So this can be asked in exams. What is NABG? This is called as N-acetyl beta-D glucosamine. I'll repeat. So the NABG is also called as N-acetyl beta-D glucosamine. So that is the most important antigen against which a lot of cross-reacting antibodies are formed. And those are the antibodies that are going to cross-react to the body's own tissues, resulting in a lot of problems that you encounter in patients with rheumatic fever and rheumatic heart disease over a period of time. So that's it. So, and there is some role of genetics as well. So for example, there are some group of people who are prone for developing rheumatic fever, but there are some certain people who don't really develop rheumatic fever even if they get exposed to the same bacteria and same antigen. So which clearly means there should be some genetic basis also. So rheumatic fever does have some genetic basis, but the exact genetic locus is still not determined properly. So how you're going to make a diagnosis of rheumatic fever? I already told you, you're going to use something called as the Duckett-Jones criteria, which has been modified several times. And remember, if you want to apply the Jones criteria, you need to have history of preceding gas infection. So that is group A streptococcal infection. Without preceding group A streptococcal infection, you cannot even apply Jones criteria. You will understand that later on. Trust me. So what are the things that come under the Jones criteria? So you have the carditis, arthritis, Synonyms chorea, and you have the subcutaneous nodules, erythema marginatum. So for example, let me tell you. So to diagnose an initial acute rheumatic fever, all you require is one major plus two minor or two major criteria, right? So all you need is like one major, two minor, or at least a two minor, or at least a two major criteria, right? More than two major criteria. So let me tell you, if a patient is having arthritis, let it be a typical migratory arthritis, it doesn't matter. And on top of that, if the patient is having elevated ESR and elevated CRP, which are basically minor criteria, do you think that the patient is having acute rheumatic fever? Can you diagnose? Tell me, can you diagnose an acute rheumatic fever just with arthritis and elevated CRP and ESR? Is it possible? Because that fulfills the Jones criteria, right? Answer me, yes or no? You can't. Yes, that's very important. You can't. So the very idea of Jones criteria is to apply in those patients with evidence of gas infection. If you do not have evidence of any group A streptococcal infection, you cannot even apply the Jones criteria. So be very clear about that. So that is the reason this evidence of preceding gas infection is very important. So how you are going to say that the patient is going to have evidence of preceding gas infection? So traditionally speaking, you can do something called as throat swab, culture sensitivity, throat swab culture sensitivity, or alternatively, we do have something called as rapid antigen testing. I think every one of you would have heard about the COVID rapid antigen testing, right? So RAT for COVID. Likewise, we have RAT for streptococcal antigen as well. But the problem is, rheumatic fever is a kind of a sequelae of infection. It's basically not the infection itself that is causing the issue. It's actually the sequelae of the infection. It's the antibodies that are cross-reacting and causing all these problems. So that's the reason why in most cases, the throat swab and or probably the rapid antigen testing for Streptococcus pyogenes is usually going to be negative. You're not going to get any results out of that. If it's positive, then well and fine. All right. If it's going to be positive, I'm completely okay with that. So that's going to be one of the best evidences for streptococcal infection. But in most cases, it's going to be negative because it's a kind of a sequelae of an infection more often than not. So that is why what we wanted to test is the antibodies. You know what are the antibodies, right? So you're going to have the ASO titers, the anti-streptolysin titers, or basically you can use something called as anti-DNSP titers also. These are the two things that we very, very commonly use in our country. Apart from that, there are plenty of other titers like anti-streptokinase titers, anti-hyaluronidase titers, and we have so many other things that we can look for it. But what we do in our country right now is ASO titers and anti-DNSP titers. So can anyone tell me at what time the ASO titers elevate? Again, this is a straight line from Harrison. When ASO titers start elevating? By approximately 1 to 3 weeks. By 1 to 3 weeks, the ASO titers start elevating. And when the anti-DNSP titers start elevating, it takes around 6 to 8 weeks. It takes around 6 to 8 weeks. So if I'm an examiner, I might frame a question based on the timing of this antibody elevation. So when ASO titers is going to elevate and when anti-DNSP titers are going to elevate. And more importantly, I might ask which is the earliest to appear. So now you're going to answer earliest to appear. It's going to be ASO titer or it's going to be anti-DNSP titer. So what is the titer that's going to be appearing early? So of course, the antibody that's going to appear early is ASO titers. So 1 to 3 weeks, but anti-DNSP takes a little bit of time. So 6 to 8 weeks. So I should have some evidence of preceding group A streptococcal infection. Without that, I'll not be able to apply the criteria at all. So you all know we have major as well as minor criteria. So 1 major, 2 minor, or at least 2 major criteria will tell you the diagnosis of acute rheumatic fever. This is only for the initial attack of acute rheumatic fever, provided the patient is having like some evidence of group A streptococcal infection. But how will you diagnose recurrent rheumatic fever, recurrent acute rheumatic fever? What is the criteria for recurrent ARF? The same criteria applies, all right? The same criteria will apply in the sense the same 1 major, 2 minor, 2 major is going to apply. Plus, apart from that, even a 3 minor criteria is enough to make a diagnosis of recurrent acute rheumatic fever. If you're thinking about a recurrent attack, apart from 1 major, 2 minor, or apart from the 2 major that we have seen already, even 3 minor criteria Even 3 minor criteria is more than enough to make a diagnosis of recurrent attack of acute rheumatic fever. That's it. And what about the major and the minor criteria? People remember by a lot of mnemonic, but I used to follow one traditional mnemonic called as peach cases. So peach cases, that's the mnemonic I follow. So technically, so you have something called as peach and you have something called as cases. So this is the mnemonic I follow. It's called as peach cases, easy one. So you all know C stands for carditis. Carditis. A stands for arthritis. S stands for Sydenham's chorea. Or first we can write subcutaneous nodules. That's better. Subcutaneous nodules. E stands for erythema marginatum. And S stands for, of course, your classic Saint Vitus dance, that is Sydenham's chorea. And what about the minor criteria? So P. So first P stands for prolonged PR interval or PR prolongation. E stands for elevated ESR. A stands for arthralgia, not arthritis, arthralgia. And C stands for CRP elevation, elevated C-reactive protein. And H stands for high temperature. That is fever, right? H stands for high temperature. That is nothing but fever. So this is the traditional mnemonic that I tend to follow, like right from my UG days. So peach cases. So can you tell me what is the difference between a high-risk population and a low-risk population? You have two types of population, right? You have high-risk and low-risk population. So high-risk in the sense, we are talking about areas where the disease is endemic. Like, for example, in India, it's a high-risk population. So what will be the difference? So what are things that are going to differ? So technically, the arthritis will differ. So I'll tell you only the most important things. Arthritis will differ. Yes, arthritis will differ. And in the minor criteria, the ESR and CRP will differ. And of course, the arthralgia also to some extent will differ. All right. So these are the things that are going to differ between a high-risk population and a low-risk population. So in high-risk population, in low-risk population, only polyarthritis is included. Only polyarthritis is included. You should have polyarthritis. Typically, it will be a migratory polyarthritis. I'll talk about the features of arthritis in a while. On the other hand, in moderate and high-risk populations, just a polyarthralgia, you need not have a polyarthritis, just polyarthralgia is enough. Or even a monoarthritis is enough. Monoarthritis is enough. The most common joint involved is technically the knee joint. So for that matters, even a monoarthritis is enough for a moderate and high-risk population. Of course, if you have polyarthritis, it's fine. But apart from that, even a polyarthralgia or even just a monoarthritis is enough to call it as a major criteria if the population that you're dealing with is moderate or high-risk population. What about ESR difference? So when it comes to your low-risk population, ESR should be at least more than 60 millimeters per hour, minimum 60 millimeters per hour. But in moderate and high-risk populations, just more than 30 millimeters per hour is enough. Even 30 millimeters per hour is enough. So what about arthralgia, by the way? So here you have to have polyarthralgia. Only polyarthralgia will be coming under minor criteria. But here even a monoarthralgia can be included under minor criteria. Just a monoarthralgia is enough for intermediate and high-risk populations. So there will be, it's not actually CRP, it's actually the ESR that, the fever that you're going to have a slight difference. Sorry for that. So when it comes to fever, in low-risk population, the cutoff for fever is you should have at least 38.5 degrees Celsius and above. But in moderate and high-risk population, even a fever of more than 38 degrees Celsius is enough. So these are some small differences. CRP, same. CRP, there is no difference. CRP in both low-risk as well as high-risk population, it is more than 3 milligrams per liter. So that's not going to be much of a difference. more than 3 milligrams per liter. That's for CRP. So what's going to differ is the ESR, the arthralgia, and of course your fever, the high temperature. So arthritis, ESR, arthralgia, and high temperature. These are the ones that are going to differ with regards to your low-risk population and high-risk population. This is what you need to know. Apart from that, everything else is almost the same. Before explaining each and every clinical feature of acute rheumatic fever, so you can tell what is this. This one is pathognomonic of acute rheumatic fever, right? So everyone knows this is a very standard and a common question. Very easy question. You'd have studied in pathology already. So every single exam, especially when it's a NB kind of exam, they tend to ask this question. So this is nothing but an Ashkoff body. That's it. So what is Ashkoff body, by the way? Can anyone say what is Ashkoff body? Ashkoff body is nothing but a collagenous band. So you're going to have collagenous band. So it's a collagenous nodule. So first of all, you're going to have a background collagen you'd have studied in pathology already. It's a collagenous nodule. Yeah, you're going to have fibrinode necrosis. On top of that, you're going to have a little bit of lymphoplasmacytoid infiltrate. Lymphoplasmacytoid infiltrate. On top of that, you have that characteristic cells, even though they are not specific for rheumatic fever, but you see that characteristic cells that have that oval-shaped nucleus. So these are the cells that have that classic oval-shaped nucleus. Can you see over here? So these are cells that have that classic oval-shaped nucleus. What are these cells? These cells are also called as Anichkov cells. Anichkov cells, right? So these are thought to be histiocytes. These are eosinophilic cells with oval-shaped nucleus. They are basically thought to be cardiac histiocytes, and they're not very specific for acute rheumatic fever, otherwise called as a caterpillar cell. So not very specific for acute rheumatic fever, but the entire structure is actually specific for acute rheumatic fever. Not just the cells, the entire structure is specific for acute rheumatic fever. So this is what we call it as the characteristic Ashkoff body, or we can call it as Ashkoff nodule. All right, very, very important. And let us have a discussion about each and every individual feature of acute rheumatic fever now. So first of all, if they ask you the most common manifestation, what you will answer? Can anyone tell what is the most common manifestation of acute rheumatic fever? Yes, you're right. Lakshmi is correct. So many people are answering correctly. Yeah, it's arthritis. Arthritis is the most common manifestation. Most common manifestation. If they ask you the most common manifestation, the earliest manifestation of acute rheumatic fever is basically arthritis. And typically, it's going to be a migratory arthritis. So what do you mean by migratory arthritis? There are many patterns. You have intermittent pattern, you have migratory pattern, you have additive pattern. Additive means one joint will be involved and sequentially other joints also will be involved on top of that. That is additive pattern. Typical example, rheumatoid arthritis. What do you mean migratory arthritis? A particular joint will be involved and that will cause a lot of trouble and that will settle down and new set of joints will be involved. So it will migrate from one area to another area. So that's what we call it as migratory arthritis, typical. And what will be the treatment of choice for arthritis? NSAIDs. They tend to show excellent response to NSAIDs. And most of the patients will tell complete improvement in the pain within 48 hours after starting NSAIDs. Any NSAID for that matters. It need not necessarily be aspirin. It could be just a kind of like Brufen or diclofenac or aceclofenac or any NSAID. Commonly what we use in our practice is ibuprofen or probably indomethacin. So they tend to have excellent response. Within 48 hours, patient will complain of literally no pain. Excellent response to NSAIDs. And yes, some of you are answering correctly. Yes, it's a non-erosive arthritis. It's not just a migratory, but it's a non-erosive form of arthritis. Very, very important. So, okay, fine. Arthritis, you know, and most common feature and the treatment is NSAIDs. So what about the second manifestation? That is carditis. And in case if arthritis occurs, it occurs within the first 3 weeks, of illness. What about carditis though? Carditis is also going to occur in the first 3 weeks only. And which will be the most common? Because when you talk about carditis, yeah, antibiotics will not be given unnecessarily. But nevertheless, let us continue with the lecture. So if you look at carditis, which is the most common feature of carditis? And you know, rheumatic fever can cause pancarditis. So you can have pericarditis, endocarditis, and myocarditis. But what is the most common feature? Is it pericarditis or endocarditis, or is it myocarditis? Actually, it is the endocarditis. Correct. Only one answer I got it right. So it's actually endocarditis. And in the endocarditis, can you say what is going to be the most common in the endocarditis? Which structure is involved more commonly? Correct. Most common is valvulitis. You're going to have valvulitis for sure. In case if there is a cardiac involvement, invariably you're going to have valvulitis for sure. There's no doubt about that. And if they ask you what is the most common valve involved, what is the most common valve involved? Can anyone say it's the mitral valve? I'll repeat, the most common valve involved will be the mitral valve. And because of mitral valve involvement, what is the most common abnormality you're going to get? What is the most common valvular abnormality you're going to get because of mitral valve involvement? And I don't think many students are going to answer this correctly. It's actually not MS, it is MR. That's the most common valvular abnormality in the setting of acute rheumatic fever. MS, yes, it can occur, but it's a sequelae of acute rheumatic fever. It's because of rheumatic heart disease. That is different. But in an acute rheumatic fever, the most common valvular abnormality that you're going to get is MR, mitral regurgitation. And because of mitral valvulitis, you might think patient is having MR, so they just have a kind of a pansystolic murmur. Actually not. Patients can develop a mid-systolic murmur just because of the mitral valvulitis. Because of the valvulitis, the blood flow across the valve during diastole will be turbulent. And that can result in a mid-diastolic murmur. It's not due to MR. I'm repeating. This MDM is due to mitral valvulitis. This MDM is a result of mitral valvulitis. What is this MDM called as? It's a very common question in exam. If MDM occurs because of mitral valvulitis, what is that MDM called as? I already got an answer, which is correct. It's Carey-Coombs murmur. That's correct. Absolutely right. We're talking about Carey-Coombs murmur. So the mid-diastolic murmur that occurs in a case of acute rheumatic fever due to mitral valvulitis itself is what we call as Carey-Coombs murmur. So Carey-Coombs murmur is one of the important differential diagnoses for a mid-diastolic murmur. All right. Remember, in acute rheumatic fever, again, I'm repeating, very commonly confused in exam. The MDM is not due to MS, rather it is actually due to valvulitis itself, and that's called as Carey-Coombs murmur. And third feature, subcutaneous nodules. Subcutaneous nodules. So these nodules are basically going to be firm and painless. They're painless nodules, very important. And most commonly, it's going to be present over the tendons and bony prominences. It will be seen over tendons and bony prominences. Very commonly in the extensor surface, rather than the flexor surface, very commonly in the extensor surface. Dr. Med is asking why MDM? That is because of valvulitis. The valve is inflamed. Because the valve is inflamed, the blood flow across the valve will be turbulent. So you know the blood flow across the mitral valve occurs during the diastole. That's where we get the mid-diastolic murmur. So all right. So the next manifestation is erythema marginatum. So can anyone describe the erythema marginatum? Remember, the most common location for erythema marginatum is the trunk. Trunk is the most common site for erythema marginatum. It's a kind of a serpentinous lesion. We cannot call it as a target lesion though. There will be a little bit of central clearing, but it's not kind of a target lesion. Target lesions will have a bullseye appearance. This will not classically have a kind of a bullseye appearance. So rather it will have a kind of a serpentinous appearance, and there will be a kind of a central clearing. And more importantly, we have to know that the expansion will be centrifugal. That will be asked in exams. Centrifugal expansion from inside out. That's called a centrifugal expansion. And there are three important things. Yeah. Central clearing, serpentinous pattern, painless, erythematous lesion, most common. So what are three things that doesn't occur in erythema marginatum? Can anyone say? So what are the no's in erythema marginatum? Which means certain things doesn't occur with erythema marginatum. So number one, no itching, no pruritus. That's correct. No pruritus. Number three, yes, never on face. Doesn't involve face. It never occurs in the face. Number two, Very important, right? Does not involve the face at all. And number 3, it doesn't scar really. It doesn't produce any scars. It doesn't leave any residual scars. So it resolves almost completely, near complete resolution. So those are the 3 important things. No itching, doesn't occur on the face, and really no scars. So these are the characteristic features of erythema marginatum. So what about Sydenham scoria? My God, this is like, we have to discuss a little bit about Sydenham scoria. Yes, it's a centrifugal spread. That's correct. Sydenham scoria. So can anyone say what is the speciality of the Sydenham scoria, by the way? More than saying about putamen or whatever. So this is a manifestation of acute rheumatic fever that has the longest latency. So these are the most important points, to be honest. So this is a manifestation that has the longest latency. So most of the manifestations of acute rheumatic fever are going to occur within 1 to 3 weeks. But this is one such manifestation that can take a long time to present. It usually takes around 1 to 8 months. And it's very common in children. And as such, rheumatic fever is quite common in 5 to 15 years. This is the classic age group of involvement of rheumatic fever. And we don't know. Indian data says that it's slightly more common in females. We don't know exactly why that occurs. And there is no real good data to substantiate that, but it's slightly more common in females compared to males. And classic age group that will be affected is 5 to 15 years. Very important point. And that's why Sydenham scoria is also quite common in children. Yes, psychiatric manifestations. So this is a disorder that's going to be associated with longest latency. And what is the most common or probably the earliest manifestation? Can anyone say what is the earliest manifestation of Sydenham scoria? Earliest manifestation. Yes, correct. So changes in the behavior, behavioral changes. So like, for example, child will become more fidgety, restless. Yeah, child will become more fidgety, restless, and emotional lability. Emotional lability. So these are the earliest changes that tend to occur in patients with Sydenham scoria, fidgetiness and emotional lability. They cry out of nowhere and they start laughing out of nowhere. So that's what we call as emotional lability. Yeah, and they can have psychiatric changes, correct. Psychiatric changes like obsessive compulsive behavior, and slowly they start developing involuntary movements, typically chorea. Involuntary movements, characteristically chorea, correct. So can you say the important manifestations of chorea? Anyone? Important manifestations of chorea? It's easy actually. So one of the important manifestations is hypotonia. Most people forget this. Yeah, chorea is basically semi-purposeful involuntary movement. That's fine. So that's all right. It's more often a kind of a distal movement than a proximal movement. That's all right. But what I'm talking about is the signs associated with chorea. So hypotonia, very, very important. Patients can have hypotonia, and these patients tend to have some characteristic signs. What are those signs? Anyone? Of course, most of the involuntary movements disappear during sleep. Dr. Ali, it's not just chorea. Most of the involuntary movements, including tremors, including Parkinson tremors, tend to disappear during sleep. Yes, there are some reflexes like hunger reflex. This can be asked in exam. Hunger reflex. And where will you test the hunger reflex typically? Where are you going to test the hunger reflex? Anyone? Hunger reflex will be tested in the ankle, correct. So you have to test in the ankle, not in the knee, not anywhere else. Yeah. Patients will be having pronator sign. Pronator sign, correct. So what is pronator sign? Even if you ask the patient to supinate the hands and keep like this, they will pronate. They will not be able to keep the hands in supinated position. If you ask the patients to stretch their hands and keep their hands outstretched like this, they're going to pronate and take the hands like this. So that is what we called as pronator sign. And apart from that, there is something called jack in the box tongue, which means they will not be able to keep the tongue in protruded position. They're going to take inward. And if you ask them to protrude outside, they'll not be able to keep there, and they're going to take inward again. So that's what we call as jack-in-the-box tongue. And patients tend to have something called as milkmaid grip. That is basically because of hypotonia. Because the patients are having hypotonia, if you ask them to like hold the finger, or if you ask them to grip something, they'll not be able to grip it completely because of the intervening hypotonia. They'll be having a kind of a strong grip and alternating weak grip. So because of this strong and alternating weak grip, it is often referred to as something called as milkmaid sign. So these are the important aspects of chorea that you have to note for. This can be asked in exam: hypotonia, hunger reflex, pronata sign, jack-in-the-box tongue, and milkmaid grip. Yeah, we'll discuss about hunger reflex because it's related to hypothyroidism also. So in a way, both are relatively similar. I'll talk about that. All right. So now I think we have discussed about almost all the important manifestations, but there are some things I missed out. So we have only talked about the carditis part, valvulitis part, but what about carditis? What is the most common manifestation of carditis? In case if the patient is having carditis, what will be the most common manifestation? What will be the most common manifestation of carditis? Tachycardia. That's the usual manifestation of carditis. They might ask you this. The patient is having extreme, like out of proportion tachycardia, you have to suspect underlying carditis. So usually because of the carditis, heart failure is rare. Heart failure is rare. Heart failure is rare. You don't get heart failure because of carditis due to acute rheumatic fever, but you can still get. So treatment, usually supportive care. And can you tell me what is the indication of corticosteroids? What is the indication of corticosteroids? You can give corticosteroids like prednisolone only in patients with moderate to severe carditis, especially in those patients who are having heart failure. If the patient is having moderate to severe carditis, especially in those patients who are having heart failure, probably you can try corticosteroids like prednisolone or dexamethasone. That's it. Otherwise, we are not going to use steroids at all. It's all about supportive care for acute heart failure, nothing more. And what is the treatment of Sydenham's chorea? So you have plenty of basic treatment and advanced level treatment. So, but what is the treatment of Sydenham's chorea? So again, it's supportive. You have to control the involuntary movements. You have to control the psychiatric changes and the emotional ability. So technically, you can use antipsychotics, no problem, no harm. You can use antipsychotics, absolutely. So like, for example, haloperidol can be tried. Yes, some people are commenting on valproate. Yes, you can try valproate also, no problem. But if they ask you what you're going to do in patients with refractory Sydenham's chorea, if the patient is having refractory Sydenham's chorea, what do you want to do? Yes, if it's refractory, you can try corticosteroids plus or minus IVIG. So this was one of the old exam questions, one of the NBE questions, NEET exam questions. So Shrishti is asking jack-in-the-box tongue. So remember, these patients will be restless and fidgety, first of all. So if you ask them to protrude the tongue, they will not be able to keep the tongue in the protruded portion. It's going to go back inside faster. So that's what we call it as jack-in-the-box tongue. I think now you can get it. That is because of the fidgetiness seen in these patients. They will not be able to maintain one position. So you want to repeat Sydenham's chorea. All right. So hypotonia, hunger reflex, pronata sign, they'll not be able to keep the hand in supinate position. They pronate and they flex it. That's what we call it as pronata sign, jack-in-the-box tongue, and milkmaid grip. That is because of alternative, like strong and weak gripping effects. So that is what we call it as milkmaid grip. And the treatment of choice, basically, it's supportive care only. So in case if the patient is having refractory Sydenham's chorea, then you can try corticosteroids, plus or minus you can try IVIG also. As I said, this is one of the old NEET exam as well as your INS-ET exam question. They asked this: what is the treatment of choice for refractory Sydenham's chorea? It's basically corticosteroids in combination with IVIG. So I think we have discussed about almost all the important manifestations of acute rheumatic fever. Do you have any doubts on acute rheumatic fever? I think we can move on, right? So next slide, it's about prophylaxis. Okay, cool. So can you prevent acute rheumatic fever from occurring? Is there a possibility? Can you prevent acute rheumatic fever? Sonakshi is asking why IVIG is given. See, remember, this is due to cross-reacting antibodies. This is basically due to what? Cross-reacting antibodies. So IVIG can be given in any condition that has like antibody excess or some antibody is causing a problem. In those situations, you can give IVIG, right? So for example, ITP, you give IVIG. In Goodpasture syndrome, you give IVIG because these are areas where the problem is due to antibodies. So that's the reason why you can use IVIG here as well. All right, understood? What is the cause of death in rheumatic fever? See, people really don't die of rheumatic fever. In case if they die because of rheumatic fever, it must be due to heart failure. Otherwise, they don't die because of rheumatic fever. They only develop sequelae, that is rheumatic heart disease, technically. Okay, fine. So remember, we are talking about prevention of acute rheumatic fever. It's very difficult. According to some data, if you can treat the pharyngitis within 8 days, you may possibly prevent, but that's a very old data. But prevention is quite difficult. You have to avoid crowded places. So it's basically based on some PSM data, that's all. Apart from that, prevention is very, very difficult. Once you get pharyngitis, people who are susceptible to it invariably ends up with acute rheumatic fever. Maybe according to old data, if you give antibiotics within 8 days of onset of pharyngitis, possibly you can treat acute rheumatic fever, but that's not clearly proven. So I'm not writing that. That's the reason I've not written that. But in exam, what they're going to ask about is something called a secondary prophylaxis. That is what is going to be more important. Secondary prophylaxis in the sense you want to prevent recurrent attacks of acute rheumatic fever. So, I mean, for moderate to severe carditis, Shreya Krishna is asking, apart from prednisolone, what else can be given? So no, we don't give anything else. I mean, supportive care is important. You're going to treat like a standard acute heart failure. That's all, nothing more than that. On top of that, you can try steroids in case if the heart failure is due to severe rheumatic fever. Okay, all right. In exams, they're going to talk about only secondary prophylaxis, right? So secondary prophylaxis, what is the drug of choice? It's benzathine penicillin. Very, very important, including the doses. Everything is important. Everything can be asked in exams. So what is the dose of benzathine penicillin? Depends on the weight. In case if the patient is more than 27 kilogram in weight, the dose is 1.2 million units. In case if the patient is like having a lower weight, like less than or equal to 27 kilogram, the dose will be 0.6 million units, which means half the dose you're going to give. And it has to be given via IM injections every 3 to 4 weeks. This is the best therapy. This is best, actually, proven in trials. This is best. This is best. Benzathine penicillin, 0.6 to 1.2 million units, depending on body weight, IM every 3 to 4 weeks. Classic therapy. In case the patient is not willing for injections, then for them, you can use something called penicillin V, which is an oral penicillin. It can be given 2 times a day. So commonly what we use in practice is a drug called as Pentets. 400 milligram, we give 2 times a day. So that is an alternative. But remember, this is inferior. This is not superior to IM penicillin. IM penicillin is best every 3 to 4 weeks once. But oral penicillin is inferior. So what are the alternatives to penicillin? In case if the patient is having penicillin allergy. So the next alternative is sulfadiazine. This is very important. Many students will answer macrolides in exam. Actually, it's not. As far as the ACCHA guidelines is concerned, if the patient is allergic to penicillin, the second line alternative therapy is going to be sulfadiazine. The standard dose of sulfadiazine is going to be 1 gram if the patient's weight is more than 27 kilogram. But if the patient is like weighing less than 27 kilogram, then the dose will be half, just 0.5 milligram. Or alternatively, the third line therapy. So the third line therapy. If the patient is having sulfa allergy also, you can't use sulfadiazine, right? So in patients with sulfa allergy. So in those patients, you can use azithromycin or erythromycin. Anyone, macrolides can be used. The usual dose of azithromycin is 6 milligram per kilogram per day. Maximum dose is 250 milligram. But in exam, if you can't remember all these doses, at least remember benzathine penicillin dose. So this has been asked so many times in exam. So now let us look at the images. Here is an image of something called as erythema marginatum. So it's very common in the trunk, especially in the back. It's a centrifugally expanding ulcer. It's not going to have pain. It's not going to scar. It doesn't occur in the face. And it doesn't cause any itching or pruritus, right? So here is an example of subcutaneous nodules. You can notice over here. So here's an example of subcutaneous nodules, very common over the tendons and over the bony prominences. All right. And how long you're going to give prophylaxis in case if the patient is having acute rheumatic fever. It depends on whether the patient is having carditis or carditis and valvulitis or no carditis and valvulitis. In case if the patient doesn't have any evidence of carditis and valvulitis in echocardiogram, so ACCHA recommends for a total duration of 5 years or until 21 years of age, whichever comes late. That's very important, whichever comes late. According to WHO, you can give for a total duration of 5 years or up to 18 years of age, whichever comes late. This is according to WHO. So if the patient is having only carditis without any valve involvement, then you can give prophylaxis for a total duration of 10 years or until 21 years of age, according to ACCHA. According to WHO, if the patient is having only carditis, you can give for a total duration of 10 years or up to 25 years of age, whichever comes late. In case if the patient is having valvulitis, according to ACCHA, you can give for a total duration of 10 years or up to 40 years of age, whichever comes late. But ACCHA also mentions, but if the patient is having severe valvular damage causing heart failure, severe valvular damage causing heart failure, or the patient ends up with rheumatic heart disease. So if the patient is having heart failure or if the patient is having rheumatic heart disease as such, or after valve surgery. So whenever you have done a valve surgery means the disease is severe. That's why you have done a valve replacement or any form of valve surgery. In this case, the prophylaxis should be lifelong, which means the most important take-home message here is, even if the patient has undergone a valve surgery, you should not stop the prophylaxis. That's a very important point. In fact, if the patient has undergone a valve surgery, you have to give lifelong penicillin prophylaxis. Very, very important point. According to WHO, any valvulitis means you have to go for a lifelong treatment, whichever comes late. Yes, I mean, whichever comes late means it's a simple one. Suppose if the patient is developing acute rheumatic fever at 17 years, let us assume patient is developing acute rheumatic fever at 17 years, and this patient is having carditis only. Carditis only. So how long you will give? How long you're going to give prophylaxis? 17 years of age, diagnosed with acute rheumatic fever, develop carditis only. How long you're going to give? Yes. Not till 21 years of age. So I told you whichever is late, right? So we have two things. So you can go up to 21 years of age according to ACCHA or 10 years total duration. So if you're going to give for 10 years total duration, you have to give up to 27 years. Or alternative is you can give up to 21 years of age. But which is late here? 27 till 27 years or till 21 years? Which is late? Which is late? Of course. So this is what you have to prefer. So that's what the meaning of whichever is late. So you have to give prophylaxis for a duration. So whichever is late, that's going to be the duration. And somebody is asking how frequently you give prophylaxis. We have discussed already, no? If you are choosing IM benzathine penicillin G, then you have to give one injection every 3 to 4 weeks. If it's penicillin V, daily. If it's sulfadiazine, daily. If it's azithromycin, also daily. I don't know who asked that question, but this is how frequently we give prophylaxis. We often prefer penicillin injections every 3 to 4 weeks. Dose will depend on the weight. So nevertheless, so this is the duration of prophylaxis, how long you have to give. So in exam, I don't know what to follow because there are 2 sets of guidelines. I don't know what examiner will be expecting, but you can follow ACCHA, no harm. So no carditis, no valvulitis, 5 years or 21 years of age. Carditis only 10 years total duration or till 21 years of age. Valvulitis only without any severe heart failure or valve surgery, total 10 years or till 40 years of age. If the patient is having evidence of any severe valvular damage like causing heart failure, or the patient has undergone a valve surgery already, then you have to opt for a lifelong prophylaxis. Okay, so that completes our discussion on acute rheumatic fever as well. Now it's time that we enter into a very important valvular heart disease, that is mitral stenosis. So if 5-year child, then for 16 years or up to 21 years. Depends on whether you're having carditis or valvulitis or no carditis, valvulitis. If you are talking about carditis, Dr. Samsung. So what Dr. Samsung is asking is, the patient is 5 years and patient is having carditis. So there are 2 options here. So you can give up to 10 years total or till 21 years of age. So if you're going to give 10 years total, it comes up to 15 years. So here, which is late? Which is late? 15 years or 21 years? So of course, this is what you have to prefer. So I told you whichever is late very clearly. So you have to prefer giving prophylaxis till 21 years of age. So that is what we're going to prefer. All right. So now it will sort out the confusion of the concept of whichever is late. Okay, coming to mitral stenosis. Let us move on to the actual valvular heart disease right now. All right. So what is the etiology of mitral stenosis? Anyone? Of course, you're going to have only one etiology for mitral stenosis, always, almost. It's rheumatic heart disease. That's it. So rheumatic heart disease is the culmination of acute rheumatic fever. Trust me, each and every time you develop an acute rheumatic fever, the damage to the valve will keep on accumulating. So rheumatic heart disease is basically nothing but a culmination of all the damages that are caused over a period of time. So that is the very basis of your secondary prophylaxis. So why we give secondary prophylaxis? To prevent that cumulative damage because of recurrent attacks of acute rheumatic fever. So once I develop acute rheumatic fever, which means I'm predisposed to development of recurrent attacks of acute rheumatic fever. The more and more acute rheumatic fever attacks I get, the more and more the valve damage keeps happening and more it keeps accumulating. And ultimately, I'm going to end up with acute rheumatic heart disease, right? So the very idea is to prevent any further damage to the valve or any further damage to the heart or any other tissue in the body because of recurrent attacks of acute rheumatic fever. And that's a very basis of giving something called a secondary prophylaxis. Do you understand? Yes or no? Are you understanding? Yes. So the number one, the most important etiology of mitral stenosis is rheumatic heart disease. My professor used to say, there are three causes of mitral stenosis. One is rheumatic heart disease. Second is rheumatic heart disease. Third is also rheumatic heart disease. So the moment you encounter the word mitral stenosis, there is only one thing that should come into your mind. That is rheumatic heart disease. That's it. Nothing more. Apart from that, there are some rare etiologies, rare problems like Luton-Backer syndrome. I'll talk about that later on. Yeah. Luton-Backer syndrome. So what is Luton-Backer syndrome? It is a combination of mitral stenosis and atrial septal defect. Here the ASD is basically congenital. So it's a congenital heart disease. We know it's a congenital acyanotic heart disease. But the mitral stenosis that you're dealing with, the mitral stenosis will be usually acquired. It's a combination of a congenital ASD with an acquired MS. Can anyone say what is the speciality of Luton-Backer syndrome? Why it is so special? Why it is commonly asked in your exams? Especially in your clinical exams. Why they tend to ask it? What is the speciality of Luton-Backer syndrome? So let me ask you a question indirectly. Do you hear a shunt murmur in ASD? Do you hear a shunt murmur in ASD? That's the question. So you hear an ejection systolic murmur, but that will be in the pulmonic area. That's different. That's a flow murmur. That's not a shunt murmur. So you don't hear a shunt murmur in ASD. Never. Because the gradient between left atrium and right atrium is like very less. It's negligible, hardly 1 to 2 millimeters of mercury. So blood flow from LA to RA is something that we cannot hear because the gradient is so low. But if you have an MS on top of ASD, and if the ASD is very small, what happens is this MS will cause increase in the left atrial pressure, and that will result in a kind of a continuous murmur across the ASD shunt. And this continuous murmur that occurs in Luton-Backer syndrome is actually because of the increased left atrial pressure, and it's because of the flow that is occurring via the defect in the atrial septum. So perhaps this is the only place where you can hear the shunt murmur in ASD. This is the only place where you're going to hear the shunt murmur in ASD. See, you shouldn't have a murmur really, but if the left atrial pressure increases, then the gradient between LA and RA increases, right? So that will cause a shunt murmur. Generally, you shouldn't hear, but this is the only condition where you're going to hear a shunt murmur in ASD. That is why this is very commonly asked in exams. Do you get it? Yes or no? So why Luton-Backer syndrome is special? So it's a continuous murmur, and it's the only place where you hear the shunt murmur of ASD. Nowhere else you're going to hear the shunt murmur of ASD, period. And third, very rare cause is mucopolysaccharidosis. Okay, infiltrative conditions. So very rarely some infiltrative conditions, like for example, mucopolysaccharidosis can result in mitral stenosis. But I mean, when it comes to India, it's always rheumatic heart disease, and rheumatic heart disease, and nothing more. And what are the hemodynamic effects of mitral stenosis? Simple. So if you look at this, you can understand very clearly in one word. If you want to say the hemodynamics of mitral stenosis, it's just increased left atrial pressure. That's it. Only one word. That's all. So everything else comes secondary. Third cause is infiltrative cause. Mucopolysaccharidosis is an example. Nevertheless, if you want to write in one single word, what is the hemodynamics? It's increased left atrial pressure. That's it. So why you're going to have increased left atrial pressure? That is because of the stenosed orifice. Because you're having a stenosed orifice across the mitral valve, the flow across the mitral valve during diastole is going to come down. Because the flow across the mitral valve during diastole is going to come down, you're going to have less blood flowing to the LV or more blood going to the LV. Less blood going to the LV or more blood going to the LV. So less blood will move to the LV, right? So the LV will be smaller, LV will be bigger. Because less blood flows into LV, LV will be smaller, LV will be big. Oh my God, Dr. Ritik, you're saying LV will be big, LV will be small. So you're going to have a small left ventricle. So if you have a small left ventricle, do you think apex will be dilated or apex will not be dilated? No problem, Ritik. Apex will be dilated or apex will be non-dilated? Yes, that's very important. Apex will be non-dilated. In a pure MS, you cannot have a dilated apex. So this is so important, so important. So do you think patients will be having LV failure or patients will not be having LV failure? Patients will be having LV failure or not having LV failure. So no, it's impossible to develop LV failure. No LV failure, never in MS. There is a famous saying, right? I'm not into any religion, but there is a famous saying called as Jesus never fails. Likewise in MS, your LV never ever fails. It's always the RV that fails in MS. LV never fails. LV will be in fact small. Apex will be non-dilated. No left ventricular failure. True MS, you don't have any left ventricular failure. And because it's non-dilated, you don't have any third heart sound also. You never hear third heart sound in left ventricle. Because only in a volume overloaded ventricle, you're going to hear third heart sound. Take me for granted. If you have a volume overloaded left ventricle or right ventricle, that's where you're going to hear the third heart sound. Here, LV is small, not having sufficient volume. So you never get third heart sound. LV never fails. And of course, what will be the contraction of LV? If the LV is small, you think it's going to contract with high force, it's going to contract with lower force. If it's going to contract with higher force or lower force? Yes, it's going to contract with lower force. So what will be the apical impulse? Apical impulse will be having lower force or higher force? Lower force. And that is what we call it as a tapping kind of apical impulse. Do you understand? What do you mean by tapping apical impulse? The apical impulse in MS will be having a kind of a lower force. It just taps you and goes, because the force is not going to be that great. Tapping apical impulse. All right. And on the other hand, your left atrial pressure is increasing. Slowly, left atrial volume is also increasing. And this is going to cause left atrial dilatation. All right. This is going to cause left atrial dilatation. In case if the left atrium dilates, in what direction it expands? In what direction it will expand? The LA dilatation, because you need to tell the X-ray changes in exam, right? In what direction it keeps expanding? It expands to the left side, it expands posteriorly, it expands superiorly, and it expands to the right side also. If it expands slightly towards the left side, it cannot go beyond the left lung margin, but if it goes to the left side, what is the X-ray sign you're going to get because of LV dilatation? Number one, you're going to get straight left heart border. What are you going to get? Straight left heart border. Very important sign. Normally, there'll be a small depression in the LA area, but if it dilates, that becomes nullified and your left heart border becomes straight. And number two, it expands up. If it expands up, who's there on the top? You have something called carina, right? On the top. If it expands up, what happens? It just splays the carina. there will be increase in the carinal angle. It pushes the carina wide apart. So there will be increase in the carinal angle, otherwise called as playing of the carina. All right. And apart from that, it expands towards the right also, towards the right atrium, because left atrium is the most posterior structure. I repeat, left atrium is going to be the most posterior structure. So it can expand towards the right, behind the right atrium. So if it goes behind the right atrium towards the right side, there will be overlapping of the shadows of the left atrium as well as the right atrium, right? So you're going to result in overlapping shadows of left atrium and right atrium on the right cardiac cell. That's going to cause double right atrial border, or we can call it as double right heart border. So that's the overlapping shadows of the right atrium and the left atrium on the right side. On top of that, in barium esophagogram, in barium swallow, in barium esophagogram, you can notice indentation in the anterior margin or posterior margin of the esophagus. Remember, esophagus is like this. The atrium is going to compress the anterior or posterior surface of esophagus. Esophagus is like this. Atrium is going from behind and it's going to indent on the anterior surface of esophagus or posterior surface. Correct. Indentation in the anterior surface of the esophagus. And in some patients, this can even result in dysphagia, right? But this is a very rare clinical presentation. This can even result in dysphagia. All right. And in case if you're going to have indentation in the posterior margin of esophagus, what will you suspect? In clinical practice, in exams, if they ask you if the indentation is there on the posterior margin of esophagus, what do you suspect? This is a very common clinical question asked in your clinical examinations. Right? What are you going to suspect? No. See, in exam, if they talk about indentation in the posterior margin of esophagus, think about a disease called as dysphagia lusoria. So what is dysphagia lusoria? It is because of aberrant right subclavian. Yeah, aberrant right subclavian that arches behind the esophagus that can compress the esophagus sometimes, resulting in indentation in the posterior margin of the esophagus. That's called as dysphagia lusoria. Dysphagia lusoria, aberrant right subclavian. So fine, that's not important right now. Anyways, so this is the effect of left atrial dilatation. So if the left atrial pressures increase, please answer. So what will happen to the pulmonary venous pressures? The pulmonary veins have to fill the left atrium, right? So what will be the pulmonary venous pressures? If this pressures increase, what will happen to the pulmonary venous pressures? Of course, you're going to have increase in the pulmonary and right heart pressures. If the pulmonary veins can't fill adequately, so what will happen? The blood will accumulate in the pulmonary circulation. So that is called as pulmonary congestion. Blood will accumulate in the pulmonary circulation. That's called as pulmonary congestion. And patients will start developing features of pulmonary congestion like crackles, shortness of breath. And sometimes they can develop hemoptysis also. Because of pulmonary congestion, some blood vessels can rupture in the pulmonary vasculature, and that can result in hemoptysis. And if the pulmonary congestion and increased pulmonary pressures, if the elevated pulmonary pressures are chronic, if the pulmonary congestion is chronic, it can result in reactive vascular changes in the pulmonary vascular bed, and that will lead to pulmonary hypertension. So what is the type of pulmonary hypertension that you're dealing over here? It's a type 1, type 2, type 3, type 4, type 5. So what is the type of pulmonary hypertension? So this is not carpulmonary. So Dr. Bipin Gowda is telling it's type 2 pulmonary hypertension. Yes, that's absolutely correct. This is a type 2 pulmonary hypertension because whenever a left heart problem is causing pulmonary hypertension, it is called type 2. Am I right or wrong? Whenever there is a left heart problem causing a pulmonary hypertension, that is called as what? Type 2 pulmonary hypertension. All right. So this is what is going to occur. Please repeat pulmonary hypertension. That is because of chronic elevation of pulmonary pressures. Because of chronic increase in the pulmonary pressures, you're going to have reactive vascular changes. The pulmonary vascular bed is going to get thickened because the pressures are very high. So that's a reactive smooth muscle change in the pulmonary vasculature. When they become thick and thick and thick and thick, the lumen will become narrowed, and that's going to increase the resistance. So your pulmonary pressures will permanently increase, and that's what we call it as pulmonary hypertension. And whenever you have a left heart problem causing pulmonary hypertension, you call it as type 2 pulmonary hypertension according to WHO classification. Type 1 is because of which mutation? It's BMPR2, bone morphogenic protein receptor 2. Because Dr. I don't know, Ashti is asking about which mutation. It's actually BMPR2, bone morphogenic protein receptor 2 mutation. Very common in type 1 pulmonary hypertension, in familial cases especially. So that's not important right now. So left heart disease causing pulmonary hypertension is typically type 2 pulmonary hypertension. That's what you need to know. And this pulmonary hypertension is going to result in what? It will result in elevated right ventricular pressures over time, and that will cause right heart failure. Right ventricular pressure overload, right ventricular pressure overload, and this RV pressure overload is going to result in right ventricular hypertrophy and slowly are going to result in right heart failure. And over time, right heart failure is going to result in features like edema, elevated JVP, that is jugular venous distension, and patients will start developing ascites, effusions, and so on. Okay. And what is a clinical sign that you notice because of right ventricular hypertrophy? If there is right ventricular pressure overload causing right ventricular hypertrophy, so what is the clinical sign that you encounter? So what clinical sign because of right ventricular hypertrophy? My God, I think if you're final year, you should be able to answer. It's not a small sign. So I'm talking about a clinical sign. Correct. Kritika, parasternal heaving. That's correct. So this is what I'm expecting. So clinically, what I'm going to notice is parasternal heaving. Perhaps, can I ask you one trivial question? So if you are good in clinical examination skills, if you have studied well, you can answer where despite severe RVH, you don't have parasternal heave. In which condition? In one condition, despite having severe right ventricular hypertrophy, you don't have parasternal heave at all. What's the condition? Anyone? 10 seconds. 10 seconds. 5 seconds. Okay, let me tell you. Let me give you a clue. It's a congenital condition. It's a cardiac condition. Oh my God, Dr. Ashti, congrats. It's tetralogy of Fallot. Correct. In tetralogy of Fallot, because of the large VST, the pressure will be easily shunted towards the left side. So you don't really have a parasternal heave. Despite having a huge RVH, you don't really have parasternal heaving. The chest will be relatively silent in most cyanotic congenital heart disease. In TOF, despite severe RVH, you don't have any parasternal heaving. Very important point. But in most cases, whenever you have a pressure overload of the right ventricle, and if that causes right ventricular hypertrophy, you're going to have parasternal heaving for sure. There's no doubt. So ultimately, the right ventricle fails, they're going to have right heart failure. Okay, Ali Usman wanted the reason for why TOF doesn't have parasternal heaving. That is because only when the pressure is transmitted outside, I mean, you can find the thrust outside. But in tetralogy of Fallot, usually there'll be a huge VST. There'll be a large VST. Because of the large VST, the pressure from the RV will be shunted towards the left ventricle easily. So that pressure is not going to get transmitted to the surface. So that's why you don't have the parasternal heave. Hope you understand it. Okay, all right. So that's fine. Okay, cool. So this is the entire hemodynamics of mitral stenosis. If you understand this, this is fine. This is enough. So what are the clinical features of MS? Anyone who's going to answer it correctly? Clinical features. So one of the usual manifestations that the patient is going to present is fatigue. Fatigue is one of the most common. SAD triad is seen in aortic stenosis, not in mitral stenosis. Mahima, you get SAD or ASD triad in aortic stenosis. So here the patient will be having fatigue. Fatigue is one of the most common clinical manifestations because of the low cardiac output. Very, very important. So you yourself said that the LV receives less blood. If the LV is going to receive less blood, do you think LV can pump out more blood? Do you think LV can pump out more blood or less blood? Because it receives less blood. It's going to pump out less blood only. Of course, because it's going to pump out less blood, you're going to have features of low cardiac output. One of the important and the earliest features of low cardiac output and heart failure is fatigue. And patients can develop shortness of breath over a period of time, plus or minus hemoptysis. Can anyone say what is the reason for shortness of breath and hemoptysis? What is the reason for shortness of breath and hemoptysis? This is typically because of pulmonary congestion. I told you already, because of increased amount of blood in the pulmonary vasculature. Because of pulmonary congestion, you're going to get shortness of breath and hemoptysis. And because of increased left atrial diameter, because of left atrial enlargement, or I can simply write as left atrial enlargement, there are some features. So what are the features of left atrial enlargement? patients can develop something called as Ortner's syndrome. So what is Ortner's syndrome? The enlarging left atrium sometimes can compress on the left recurrent laryngeal nerve, resulting in hoarseness of voice. Very important point, very commonly asked in exam. The enlarging left atrium can sometimes compress on the left recurrent laryngeal nerve, which is nearby. So that can result in hoarseness of voice. That's what we call it as Ortner's syndrome. So MS causing hoarseness of voice, Ortner's syndrome. And they can cause something called as Winter's bronchitis as well, because LA in the initial stage of enlargement, it's going to compress on the left main bronchus predominantly. It can result in a kind of a bronchitis often referred to as winter bronchitis. This is another very important key point for exams, Ortner's syndrome and winter bronchitis. And apart from Ortner's syndrome and winter bronchitis, enlarging left atrium. Yeah, enlarging left atrium can result in a very important arrhythmia. What arrhythmia you will get in left atrium enlargement? Of course, patients will develop atrial fibrillation. Yes, correct. So remember, the risk of like stroke in the setting of MS is 20 to 50 times more compared to the general population. This is not a data which is like a kind of a joke. The risk of stroke in patients with MS is 20 to 50 times more than that of the general population. Very high risk of stroke because of very high risk of atrial fibrillation. Ortner syndrome, once again, Dr. Asta. Ortner syndrome is nothing but enlarging left atrium compressing on the left recurrent laryngeal nerve, causing hoarseness of voice because of vocal cord palsy. Okay, so atrial fibrillation is going to cause thromboembolic manifestations. Do you agree with me? So atrial fibrillation increases the risk of thromboembolic manifestation. Yes, all right, cool. So these are the clinical features: fatigue, shortness of breath, plus or minus hemoptysis due to pulmonary congestion, and Ortner syndrome and winter bronchitis because of left atrial enlargement. LA compressing on left recurrent laryngeal nerve is Ortner syndrome causing hoarseness of voice. LA compressing on left main bronchus causing a kind of bronchitis and hemoptysis called as winter bronchitis. And LAE can also result in atrial fibrillation, which can result in thromboembolic manifestations and stroke. Yes, 20 to 50 times more compared to the general population. Okay, now coming to the examination findings. So there are so many things in this, but let me try and concise it as much as possible. So let us talk about the pulse. So tell me one thing. So if the LV pumps out less blood, your pulse will be weak or pulse will be strong? Pulse will be weak or pulse will be strong? Pulse will be weak. So patients are going to have a kind of hypokinetic pulse, correct? Pulse will be hypokinetic in nature. It will be, generally we don't use the term low volume and high volume pulse, Dr. Sri Preeta. So technically, according to Osler, we should use the term small volume and large volume pulse. You have to say hypokinetic small volume pulse. The term has to be like clear: small volume, large volume pulse, not low volume or high volume pulse. Okay. So pulse, all right. Then what about the JVP? So do you think, will there be any alteration in the JVP? JVP will be normal. JVP will be normal in most cases, because in any left-sided problem, JVP will not be affected unless and until the patient is having severe heart failure. So in case if the JVP is increased, so what will be the usual cause? It will be due to pulmonary hypertension. JVP will be increased only in case of pulmonary hypertension. So what will be the wave that will be prominent in the setting of pulmonary hypertension? A wave. So most of the times, if you have pulmonary hypertension, you're going to have a large V wave. Apart from that, JVP will be normal in a pure MS without any pulmonary hypertension. On top of that, in case if the examiner mentions absent A wave, if the A waves are absent, what do you have to suspect? You have to suspect atrial fibrillation, correct? So in atrial fibrillation, once AF sets in, you're going to result in absent A wave. And what about the apical impulse? Please tell. Apical impulse. I told you so many things. Apical impulse. It will be tapping. Character will be tapping, whether it will be displaced or non-displaced. Very important point. It will be non-displaced. Please don't say it's going to be displaced. It will be 100% non-displaced. If you say displaced apical impulse in a pure and true MS, you'll be like going to struggle in exams. So that's not the point that you have to say. So it will be non-displaced. Same place. Normal apical impulse location. Tapping is the quality of the apical impulse. I don't know. Dr. Shreya Krishna is asking tapping, not displaced. Tapping is the quality of apical impulse. Displacement is whether it's moved to some other place or not. It's in the same location, but the character is tapping. Okay, what about the first and the second heart sounds? So what about S1? But hypertrophy so displaced. Where is hypertrophy here in LV? My God, Mahima, where is hypertrophy in LV? Hypertrophy of LV here? Is there any, guys, is there any hypertrophy of left ventricle over here in a patient with MS? Is there any hypertrophy? No, there's absolutely no hypertrophy. In fact, LV receives less blood. How can it get hypertrophy? It's impossible. Okay. So what about first heart sound? S1. S1 will be loud. There are a lot of reasons for why S1 is loud. Another very important point. So the main reason for loud S1 is increased left atrial pressure. Main reason for loud S1 is increased left atrial pressure. Asta is asking what JVP again. So I wrote clearly, in left heart problems, you don't have elevated JVP. It will be a normal JVP. Only if there is an associated pulmonary hypertension or right ventricular failure, JVP will be increased. In pulmonary hypertension, you're going to have large J wave. In case if you have absent J wave, it's going to be atrial fibrillation. So, okay, fine. You're going to have loud first heart sound, and that is because of increased left atrial pressure. And see, there are some interesting theories, but all of these things are not important for undergrad. So because of increased left atrial pressure, the valve will open for a wider distance. Because it closes from a wider distance, it closes with the bang. So that's the mechanism typically taught to an undergraduate, even though it's not 100% correct. So this is an old mechanism that our professors used to teach. Because of higher left atrial pressure, it opens for a longer distance. And then because it closes from a wider distance, it closes with the bang, like a door. So that's the reason why you get loud S1. So loud S1 implicates one important thing. Loud S1 indicates one important thing. What is that? It indicates that the valve is pliable. Very, very important point. So if the patient is having loud S1, you can say that the valve is still pliable, which means the valve is still at least relatively mobile. So where you can get soft S1 in MS? Where you can get soft S1 in MS? Can anyone say? Of course, in very severe MS, for example, in a calcified MS, you're going to get a soft S1 if there is severe calcification. So is that the only cause? Anything else? If the patient is having associated moderate to severe MR, if there is also associated MR, you're going to get a soft S1. Anything else? If the patient is having prolonged PR interval, or if the patient is having severe bradycardia, patients can have a soft S1. Generally, congestive cardiac failure is rare. You don't get in MS at all. In case if there is an associated CCF, you're going to have a soft S1. So these are the usual reasons for soft S1 in MS. Otherwise, it's going to be a loud S1. MS with infective endocarditis. First of all, MS patients are at extremely low risk or almost a zero risk of developing infective endocarditis. Remember, the risk of infective endocarditis again depends on the gradient. Do you think the gradient between LA and LV during diastole is very high or very low? The gradient between left atrium and left ventricle during diastole is high or low? It's extremely low. It's hardly like 4 to 6 millimeters of mercury. It's very, very low. Whenever there is a low gradient, the damage to the valve will be very less. And because of that, the risk of developing infective endocarditis is very, very low. So MS is one of the valvular heart diseases with extremely low risk or no risk of infective endocarditis. We never see a patient with MS with infective endocarditis. MR, yes, it can, because that event is going to occur during systole. But MS, no, you don't get infective endocarditis. Okay, all right. So where you get soft S1 in MS? Whenever the patient is having a calcified valve or associated moderate to severe MR or prolonged PR interval or severe bradycardia, or the patient is having CCF, that's a very rare cause. In that case, you can have a soft S1. Otherwise, no. So what about the second heart sound? Second heart sound is not that important, to be honest, when it comes to MS. The extra sound is the one that's going to be more important. What is the most important extra sound that you hear in MS? It is the opening snap. So what is the reason for opening snap? Once again, it's the elevated left atrial pressure. So that's the reason for the opening snap that you hear. Yes, loud P2 in pulmonary hypertension, that's different, but the extra sound is going to be most important. It's the opening snap. So whenever you hear opening snap, it indicates high left atrial pressure. Because of high left atrial pressure, when the valve opens, normally it should not produce any sound. Whenever the valve opens, it should not produce any sound. But if it produces sound, it's abnormal. If the atrioventricular valve, when it opens, produces a sound, it's called snap. When a semilunar valve, when it opens, if it produces sound, it's called as a click. That's called as an ejection click. Here you're going to call it as opening snap. Okay, so opening snap means it's mitral or tricuspid. Ejection click means it's aortic or pulmonary. Do you understand? Yes or no? Opening should not produce sounds. If it produces sounds, it's abnormal. Here you see something called as opening snap. So whenever you hear opening snap, it indicates that the valve is still opening well and the valve is pliable. So it again indicates pliability of the valve. So clinically, you can determine pliability. If you have opening snap, you can say that the valve is still pliable. So tell me, if the left atrial pressure is very high, the valve will open faster or the valve will open slower. If the left atrial pressure is very high, extremely high, the valve will open faster or slower? Yes, it's going to open faster. So there is something called as S2, or we can call it as A2-OS gap. A2-OS gap. So if the gap is shorter, you think the severity is more or severity is less? If it opens faster, and because of that, if the gap becomes smaller, it's a severe MS. That's why it's inversely proportional to severity. A multiple times asked question. S2-OS gap, or we can call it as the A2-OS gap, is inversely proportional to severity. Whenever the S2-OS gap is short, it indicates more severity because it indicates very high left atrial pressures. Okay, that's very important. And somebody asked about S2 loud P2. Yes, you can hear loud P2 in case if the patient is having pulmonary hypertension. That's correct. And apart from that, you can hear even a narrow splitting of the second heart sound. Whenever they talk about narrow split S2, it invariably indicates pulmonary hypertension in exam. Narrow split S2, pulmonary hypertension. Loud P2, pulmonary hypertension. Two things. I'll repeat. Loud P2, pulmonary hypertension. Narrow split of the second heart sound, again pulmonary hypertension. Fine. So what about the murmurs? What's a classic murmur? Everyone knows the classic murmur, that is the mid-diastolic murmur that you hear maximally in the apex because it's the problem of left ventricle technically. So the blood is not moving to the left ventricle. You hear in the apex predominantly. And this MDM will increase with expiration or inspiration. You know, the flow to the left side is going to increase with expiration. The flow to the right side is going to increase with inspiration. So because the flow to the left side increases with expiration, this murmur is going to increase with expiration because almost all the left-sided events, every single left-sided event will increase with expiration. And the murmur will be heard best in which position? Can you say in which position the murmur will be heard, especially if it's a left-sided murmur, like especially a mitral murmur? Which portion it will be heard best? Left lateral position. Left lateral, best heard. And this is a murmur that is low-pitched or high-pitched. Low-pitched or high-pitched? It's basically a low-pitched murmur. Because it's a low-pitched murmur, you're going to hear best with the stethoscope's bell or the diaphragm. Yes, you're going to hear best with the bell of the stethoscope, not with the diaphragm of the stethoscope. So classic mid-diastolic murmur in the apex, that's going to augment with expiration, and the murmur will be best heard in the left lateral portion. And typically, because it's a low pitch murmur, you're going to hear best with the bell of the stethoscope and not with the diaphragm of the stethoscope. So that's how you can explain the murmur. And whenever they talk about mid-diastolic murmur, what is the most important differential diagnosis for mid-diastolic murmur? There are two important DDs for mid-diastolic murmur. So one is going to be the Carey-Coombs murmur, right? So one is going to be the Carey-Coombs murmur that's going to occur in the setting of acute rheumatic fever. And second one is the Austin-Flint murmur. Second one is Austin-Flint murmur. That's going to occur in the setting of severe aortic regurgitation. It's a kind of functional MS. We'll talk about that later on. That occurs in severe aortic regurgitation. That's called as Austin-Flint murmur. And third, probably tricuspid stenosis. But the thing is, like, this murmur will be heard better, not in the apex, rather it will be heard better in the left lower sternal border, and it's going to get augmented with inspiration and not with expiration. It won't be late that I'll come back to that. So this is the characteristic MDM of MS, and these are the important differential diagnoses for mid-diastolic murmur: Carey-Coombs, Austin-Flint, and tricuspid stenosis. Okay, all right. So that completes our clinical features. And look at this diagram. So this is a hemodynamic diagram. So this is what we called as the famous Vickers diagram. So you know that there is something called like hemodynamic diagram that is given in all the physiology textbooks. It's often referred to as Vickers diagram. So here are the plot between the LV and the LA pressures. So can you notice that the LA pressures are high during diastole? So remember, this is systole and this is during diastole. During diastole, the pressure between LA and LV should equalize or it should not equalize. During diastole, when the mitral valve opens, the pressure between LA and LV should equalize or it should not equalize. It should equalize, right? But here, because of the stenosed orifice, the pressure will not equalize. And they're going to have a persistently increased left atrial pressure. Can you notice? You're creating a pressure gradient over here. So the pressure between LA and LV is not equalizing here. There is a persistent increase in left atrial pressure. And that is the blue shaded area. This is the pressure gradient. And that is what is causing the classic mid-diastolic murmur. That's what is causing the mid-diastolic murmur. And you can clearly notice that you get the second heart sound. And after the second heart sound, because of the opening of the mitral valve, you get the opening snap. And immediately after the mitral valve opens, which is marked by the opening snap, you start getting the murmur. So it's in the middle of the diastole. S2 to S1 is the diastole, and middle of the diastole getting the murmur. That's why it's the mid-diastolic murmur. And slowly the gradient disappears. Why? Because slowly the blood will anyway move into the left ventricle. So the gradient will slowly come down. But at one point, it will get augmented again. So why the murmur gets augmented at the end of the diastole? So this is the diastole, right? So this is the diastole. So why at the end of the diastole it gets augmented? Can anyone say why at the end of the diastole it gets augmented? Yes, it's because of atrial contraction. That's because of atrial kick. We call it as atrial kick or atrial contraction. Right? So that atrial contraction is going to augment the murmur once again. And can you say what is this phase? From S1 to S2, if this phase is diastole, what is this phase then? Tell me what is that phase? This phase from S1 to S2. S1 to S2 is systole, right? This murmur is occurring just before the systole, right? This augmentation of murmur is occurring just before the systole, and this is because of the atrial contraction. This is what we call it as pre-systolic accentuation. This is what we call it as pre-systolic accentuation. Correct? So if somebody asks you what is the reason for pre-systolic accentuation, what are you going to answer? It's atrial contraction, atrial kick. That's the reason for this pre-systolic accentuation of the murmur at the end of the diastole. So if I ask you in which condition you're going to lose the pre-systolic accentuation, can you tell me? In which condition you're going to lose the pre-systolic accentuation? It is the condition where you don't have atrial contraction. So once you start developing atrial fibrillation, you will lose the pre-systolic accentuation. Are you clear? Yes or no? So once you develop atrial fibrillation, you lose the pre-systolic accentuation, right? So the classic MDM with pre-systolic accentuation. So are you understanding this hemodynamic diagram? It's so simple, right? So you're having a gradient between LA and LV, which should normally not be there. And there is a slight increase in the gradient just before the systole because of atrial contraction. And that's causing the pre-systolic accentuation. And in atrial fibrillation, you will lose it because you lose the atrial contraction. Perfect. All right. Now, how are we going to assess the severity? So slowly we are building up the concepts now. So we are going to slowly go into a higher dimension. I know it's a little too much, but it's easily understandable. Severity. So when it comes to severity in mitral stenosis, we always look at something called as pressure half time. So we look at something called as diastolic pressure half time. So what is pressure half time? The time taken for the pressure to become half. Let me repeat, the time taken for the gradient to become half, the pressure to become half, the gradient to become half. So look at this diagram again. Look at this diagram again. So this gradient, okay, there is a gradient over here. Initially, when the mitral valve opens, the LA pressure will be more than the LV pressure slightly. And do you think normally it will take less time for the pressure to become half quickly, or it's going to take more time? Normally, it's going to take a long time for the pressure to become, the gradient to become half, or less time. normally, if the mitral valve is normal, if the mitral valve is normal, the gradient is lost very fast or gradient is lost very slow. It's going to take less time for the gradient to become half. But in the setting of MS, the gradient will be maintained for a long period of time, which means you're going to have more time. You're going to have a long time for the gradient to become half if the MS is severe. So now, after understanding the concept, just give some numbers to it. That's it. So I can say, if the pressure half time is more than 150 millisecond, you're going to call it as severe MS. If it's less than 150 millisecond, it's called as progressive MS. Do you understand the concept at least? So don't worry about the numbers. Numbers are there all the time. Can you understand the concept? If it takes a long time for the gradient to become half, means it's a severe MS. It's a tight MS. The gradient is maintained for a long time. The LA is not able to decompress its gradient, decompress its pressure faster. That's why the pressure half time is more than 150 millisecond. It gets a severe MS. And actually, mitral valve area is calculated by the formula, something called as 220 divided by pressure half time. So this is a beautiful formula, wonderful formula. So it's the commonest formula that we use for measuring the mitral valve area. Normal mitral valve area is approximately 4 to 6 centimeters square. So 220 divided by pressure half time. So can you tell me how beautiful the relationship is? If the pressure half time increases, do you think the mitral valve area is less or more? Or you can call it another way. If the mitral valve area is less, what about the pressure half time? It will increase or it will decrease? If the mitral valve area is low, what will happen to pressure half time? It's inversely proportional, right? So the pressure half time should increase. So that's what exactly we are talking about here. Are you understanding? The formula for mitral valve area is 220 by pressure half time. So technically, if the mitral valve area keeps decreasing, if the valve gets more and more stenosed, which means the pressure half time is going to increase. Or alternatively, we can find out the pressure half time in echo and find out the mitral valve area. Are you understanding? Yes or no? Both are inversely proportional. So why 220? That is based on some formulas. Don't worry about that. The machine, even we don't do that. The machine is going to calculate for us. So don't ask why 220. That's beyond the scope of the current discussion, right? So the formula is 220 divided by pressure half time. PHT is pressure half time. The time taken for the pressure gradient to become half. So if it's longer, it's more severe. If it's longer, the mitral valve area is lesser. So technically, the normal mitral valve area is 4 to 6 centimeters square. If it's going to be less than 1.5 centimeters square, we can call it as severe MS. If it's less than 1.5 centimeters square, it's severe MS. If it's more than 1.5 centimeters square, it's kind of a progressive MS. Obviously, whenever the valve area is very less, it indicates a severe MS. And what is PASP? Pulmonary artery systolic pressure. PASP. PASP stands for pulmonary artery systolic pressure. Do you think if the patient is having pulmonary hypertension, it's a severe MS, or if the patient doesn't have pulmonary hypertension, it's a severe MS? I'm asking very simple leading questions. If the patient has pulmonary hypertension, you think of severe MS, or if the patient is not having pulmonary hypertension, means severe MS? Just answer yes or no. If the patient has pulmonary hypertension, means it's severe MS. If the patient has pulmonary hypertension, the pulmonary artery systolic pressure will be more. By default, if it's more than or equal to 30 millimeters of mercury, it indicates a severe MS. If it's less than 30 millimeters of mercury, it indicates a progressive MS. So technically, if any one of this is there, it indicates a severe MS. That's it. So let me repeat. What are the findings of severe MS? Pressure, diastolic pressure half time more than 150 milliseconds, mitral valve area less than 1.5 centimeters square, and PASP more than 30 millimeters of mercury. Even though this can be a very complex concept, if you understand, tell yes, I'll move on. Yes or no? Yes. All right. Let us move on to indications for surgery. Clear? So remember, PASP stands for pulmonary artery systolic pressure. Fine. So let me tell you the common rules for indications for surgery. Remember, if you study Harrison, the one problem that you're going to face is you're going to have flowcharts everywhere. And that flowchart, by the time you study, itself is going to be confusing. Even if you find a way to somehow mug up those flowcharts, it's very difficult to comprehend and remember them. So let me give you 2 important rules on how to remember the indications for surgery. Rule number 1. symptomatic severe valvular heart disease. Class 1 indication for surgery for any valvular heart disease. Let me repeat. Symptom and severe valvular heart disease. Symptomatic severe valvular heart disease. Number 1, class 1 recommendation for surgery. Any valvular heart disease. Doesn't matter. Number 2, you can do surgery or any intervention in asymptomatic valvular heart disease also, but patient should have some complications because of valvular heart disease, right? The complications of that valvular heart disease depends on that particular valve problem, right? Only two rational, that's all. 1, symptomatic severe valvular heart disease. Number 2, you can do intervention even in an asymptomatic valvular heart disease, but patient should have some complications because of that valvular heart disease, right? So let me tell you, first one. Here we are talking about MS, so just replace everything with MS. So symptomatic severe MS. Are you understanding or not? Yes or no? Point number 1 clear, right? If the patient is having symptoms along with severe MS in echocardiogram, it's an indication for surgery. Simple, that's all. Number 2, even if the patient is not having severe MS, even if the patient is asymptomatic, patient is not having any symptoms, plus if the patient is having severe MS, still you can proceed with surgery. Still you can proceed with surgery, but patient should have some complications. Plus some complications because of your MS. So what could be the complication? What could be the complication? Tell me. MS produces what complication? Even before pulmonary hypertension. I told you one thing. So that causes stroke, 20 to 50 times higher risk of developing stroke. AFib, yes, new onset atrial fibrillation. Very important. New atrial fibrillation. Number 2, many people are commenting pulmonary hypertension, but it should be severe, not just simple pulmonary hypertension. It should be severe pulmonary hypertension. When it comes to MS, the definitions are very simple. If the patient is having pulmonary artery systolic pressure of more than 50 millimeters of mercury at rest, or if it's going to be more than 60 millimeters of mercury with exercise, this becomes an indication for surgery. That's it. This becomes an indication for surgery. More than 50 millimeters of mercury at rest or more than 60 millimeters of mercury with exercise. Are you understanding the concepts behind it? Very, very simple. So any symptomatic severe valvular heart disease or asymptomatic severe valvular heart disease, provided you have some complications of that valvular heart disease. In this case, it's going to be either a new AF or severe pulmonary hypertension, defined as past more than 50 millimeters of mercury at rest or more than 60 millimeters of mercury with exercise. Are you understanding? Yes or no? That's the logic. Only 2 things. That's what I want you to know. Don't study any algorithm. Don't study anything else. This is more than enough. So at an undergrad level, even at a postgrad level, they're not going to ask anything more than that. How you're going to measure pulmonary hypertension? In echocardiogram, obviously. The pulmonary artery systolic pressure will be measured in echocardiogram. So that's why we have echo, right? So I told you already. So the past can be measured in echocardiogram. And what is the intervention that you're going to try? So what is the first choice? If you're planning for surgery or any intervention, what is the first choice? We do something called as PMBV. So what is PMBV? That's called as percutaneous mitral balloon valvotomy. That's the first line measure. So percutaneous mitral balloon valvotomy. So what is percutaneous mitral balloon valvotomy? Very simple. I'm going to introduce, let me tell you, listen carefully. I'm going to introduce a catheter along the femoral vein. First, I'm going to poke the femoral vein. From the femoral vein, I'm going to go along the IVC, and then I'm going to enter the right atrium. And upon entering the right atrium, I'm going to put a puncture and enter the left atrium. So basically, this procedure involves a transseptal puncture. I'm going to create an iatrogenic ASD, but that will close off. Don't worry. Don't think that you're going to have problems because of ASD. So I'm going to create a kind of iatrogenic ASD, transseptal puncture from RA to LA, and go near the mitral valve, and then elevate and then put a balloon near the mitral valve orifice and expand the mitral valve area. The main problem in MS is very low mitral valve area. So if I'm going to expand that mitral valve area with a balloon, your MVA will expand, and that's going to reduce the left atrial pressure. Once the mitral valve area expands, the left atrial pressure will come down, and you can demonstrate that on table. On table, you can see that the gradient will come down, and then you're going to take the catheter out. Are you understanding what is PMBV? That is percutaneous mitral balloon valvotomy. Yes or no? I mean, in a simple sense, Shreya Krishna is saying no. In simple sense, you're just putting a balloon in the mitral valve orifice. And you're just trying to expand the balloon, expand the area, so that once the mitral valve area increases, the left atrium now can freely move the blood into the left ventricle. So the gradient will come down. The left atrial pressure will come down. So that's the idea. So that's the first choice procedure, PMBV, percutaneous mitral balloon valvotomy. And to do a mitral balloon valvotomy, you need to have a pliable valve. Only if the valve is pliable, I can do mitral balloon valvotomy. So I can say, what are the contraindications for PMBV? So not really calcific MS. We are going to use something called as, maybe I can say, non-pliable valve. If the valve is non-pliable, which means one example is calcified valve, I cannot do. My balloon remains there, or obviously we have to remove the balloon back. So it's only for dilatation. Once dilated, everything will be removed. Whole apparatus will be removed out. So that's the idea. Okay. Yes, number 2. So if you expand that area, and if the patient is having moderate to severe MR, it can cause more regurgitation. That is why if the patient is having moderate to severe MR, it's contraindicated. You cannot do that if the patient is having moderate to severe MR. And that is the reason why, while doing PMBV, because it's a catheter-based procedure, you have to perform dye injection. You have to inject the dye, and you have to see how much dye is coming back from the left ventricle, back into the left atrium, so that you have to assess the MR. By simple rule of thumb, we have some grading system inside the cath lab. So if the grade is 2+ and above, that's contraindicated. You cannot do, because if you expand that area, if there is a severe MR, it's going to get worse. That's why you cannot do in moderate to severe MR. Number 3, suppose if the patient is already having a left atrial clot because of atrial fibrillation, can you expand the area and push the clot into the left ventricle? Is that worth? Are you able to do it? No, you can't do it. The patient is already having a LA clot. If you expand the area, if you expand the mitral valve orifice, the clot will move into the left ventricle, and from there it will go somewhere else. So you can result in thromboembolic manifestation. These are the 3 most important contraindications of PMBV. Suppose if you have contraindications, if any of the contraindications are there, the treatment of choice becomes mitral valve replacement, MVR. The problem is mitral valve replacement is an open heart surgery. Yes, it's open heart surgery. It will be done by midline sternotomy. You're going to cut open the sternum. So it's not possible. The final question is how you're going to assess the pliability of the valve. How can you say that the valve is not pliable? Again, I'm going to use echocardiogram only for that. In echocardiogram, I'm going to use a score called as Wilkins score. Can be asked in exams. I'm going to use a score called as Wilkins score. If the score is more than 8, it indicates the valve is non-pliable. I'm going to use a score called as Wilkins score. If the score is more than 8, I can say that the valve is non-pliable, and I cannot perform a percutaneous mitral balloon valvotomy. So what are the components of the Wilkins score? Number 1, leaflet mobility. So how mobile the leaflets are. So I'm going to look at the mobility of the leaflets. These are the variables. And number 2, how thick the valves are. I'm going to look at the valve thickening, how thick the valves are. Valve thickening. Number 3, I'm going to look at the amount of calcification of the valve, amount of calcium deposits in the valve. Number 4, finally, I'm going to look at the degree of subvalvular disease, how much subvalvular disease I'm having. So these are the 4 important components of the Wilkins score. At least the components has to be known for exams. 4 components. 1, leaflet mobility. Number 2, valve thickening. Number 3, calcification. Number 4, degree of subvalvular disease. All right, so that completes our MS, and let me ask this question. So you're going to answer this clinical weakness. Which of the following factors is not a part of echo assessment of the mitral valve in patients with MS who are considered for valvuloplasty? Which means technically I'm asking which for the following is not a component of the Wilkins score. So A, calcification of the mitral valve, B, thickening of the mitral valve, okay, C, mobility of the mitral valve, and D, annular dilatation. As simple as that. Answer is D. It's annular dilatation. That's the right answer. So because that is not a component of the standard Wilkins score, and that's not going to be used for assessing the pliability of the valve. Okay. All right. Simple question. Now let us move on to the next valvular heart disease, that is mitral regurgitation. So what is the etiology of mitral regurgitation? So let me keep it simple. I'm not going to discuss much of complicated stuff. I'm going to just keep things little simple and relatively simple. Annular dilatation means you have something called annulus, right? So annulus. So if the mitral valve annulus dilates, yes, it's going to commonly result in MR. So that's what we call as annular dilatation. So nevertheless, so what are the etiologies of like your MR? So first of all, MR has to be classified into two types. One is called as primary MR versus something called as secondary MR. So you have something called as primary versus secondary MR. So what is the most common cause of secondary MR, by the way? I mean, which is more common? You think primary MR is more common or secondary MR is more common? Which is more common in the world right now? It's actually secondary MR. Secondary MR is the most common form of MR. And what are the causes of secondary MR? The most common cause of secondary MR is heart failure. Most common cause of secondary MR is heart failure, CCF. That's the most common cause. And the usual, otherwise secondary MR can be due to other causes like dilated cardiomyopathy that occurs in some patients, or it can be due to ischemic heart disease, or we have a kind of MR called as atrial MR that occurs in the setting of atrial fibrillation sometimes. But the single most important cause of secondary MR is heart failure, any heart failure, because the LV dilates. Because the LV dilates, the annulus will dilate. So the valves normally should close, but the valves will start moving apart. So they will not be able to coap together properly, and that can result in an MR. So that's why the CCF is the usual reason for secondary MR. Heart failure itself can result in secondary MR. So primary MR means the main problem is the valve apparatus itself. So primary MR is basically due to degeneration of the valve apparatus. So look at this diagram, you can understand things better. So the valve problem can be a leaflet problem. The problem can be in the leaflets. The problem can be in the chordae tendineae, or problem can be in the papillary muscles. These are the three important areas where the problem can be located. So classic example of a leaflet problem. Classic example of a leaflet problem is mitral valve prolapse. That is because of myxomatous degeneration of the mitral valve resulting in prolapse. So MVP need not result in MR all the time, but in some cases there will be a late MR that can occur in mitral valve prolapse. And of course, you know that rheumatic heart disease itself is a valve problem, right? So that can result in MR. And infective endocarditis, yes, it causes severe damage to the mitral valve or any valve, even aortic valve for that matters. That can result in MR. Or in patients with hypertrophic cardiomyopathy, there will be something called a systolic anterior motion of the anterior mitral leaflet. That can result in MR. The mechanism of HOCM causing MR is quite interesting. Let me tell you what happens. So let me draw something like this over here. And let us assume this is the left atrium and this is the left ventricle. And let us assume here is your LVOT maybe. So this is the left ventricular outflow tract. And here is your aortic valve and here is your mitral valve. Okay, so this is the mitral valve and this is the aortic valve. So normally blood has to move from LA to LV and then from LV into the aorta. So here is the aorta. Okay. So where is the problem in HOCM? The problem will be at a subvalvular level. So there is going to be some septal hypertrophy at this point. So this patient is going to have a LVOT obstruction. This patient will be having a left ventricular outflow tract obstruction. That is because of the septal hypertrophy, or we can call it as asymmetric septal hypertrophy. So the blood has to flow across the obstructed left ventricular outflow tract. So whenever, tell me one common rule, whenever blood flows across an obstructed left ventricular outflow or across any obstruction, what is going to happen? The velocities will increase or velocities will decrease? Tell me. So this is a common rule of thumb. If there is an obstruction, if there is a straight tube, if there is an obstruction, and if the blood is flowing across that obstruction, what will happen to the velocity? The velocity, of course, will increase. And whenever there is an increased velocity, what will happen to the pressure by Bernoulli's effect? And by Venturi principle and Bernoulli effect, whenever velocity increases, what will happen to the pressure? Pressure will drop simultaneously. That is to conserve momentum. That's called law of conservation of momentum. Velocity increases, pressure drops. So at the LVOT, what will be the pressure? At LVOT, what will be the pressure? Pressure will drop, or because of high velocity, what will happen to the pressure over here? So pressure is going to basically decrease at this point because of a low pressure area that is created over here. So what will happen to this particular leaflet of mitral valve? What will happen to this particular mitral valve leaflet? So you're having a low pressure at this point. So what will happen to this mitral valve leaflet? It's going to be sucked towards low pressure, or it will be blown away from the low pressure region. Whenever you have low pressure, you're going to suck it or you're going to blow away. You're going to suck it or you're going to blow away. Yes, of course. This valve will be sucked towards the left ventricular outflow tract. So now you can understand that during systole, tell me, during systole, your mitral valve should close or mitral valve should open. Think clearly. During systole, when the left ventricle contracts, the mitral valve should close or mitral valve should open. Mitral valve should close, right? But what's happening here? Mitral valve is basically showing an abnormal motion, and that is moving towards the left ventricular outflow tract. This abnormal anterior motion of the mitral valve towards the left ventricular outflow tract in patients with HOCM. So this is the AML, this is PML. This is called as systolic anterior motion of the anterior mitral leaflet. Do you understand? What do you mean by systolic anterior motion of the anterior mitral valve or anterior mitral leaflet towards the LVOT? Are you understanding or not? Yes or no? So this AML is going to abnormally move towards the left ventricular outflow tract. So because it's sucked towards the LVOT, and that's what we call it as systolic anterior motion, an abnormal systolic anterior motion of the anterior mitral leaflet. And if the AML moves towards the LVOT and it's not closing properly, you're going to result in MR, right? There'll be a jet moving towards, and that's going to cause MR. Are you understanding the mechanism of MR due to systolic anterior motion HOCM? Yes or no? Please say yes or no, so that I can move forward. Yes, so that's the mechanism of MR in patients with HOCM. Okay, so or the problem can be because of the chordae tendineae. So where the chordae will rupture, it can be an idiopathic rupture, or it can occur in the setting of infected endocarditis because of infection, vegetations causing rupture, or the problem can be in the papillary muscles. So where you get papillary muscle dysfunction, classic condition, I've told you so many times, people who have attended my lecture should be able to answer this. It occurs in acute myocardial infarction. We discussed that already so many times, acute myocardial infarction. And that too in acute MI, which papillary muscle typically tends to rupture? The posteromedial papillary muscle, because it has a single blood supply. The posteromedial papillary muscle, because it has single blood supply. Where it is coming from? It's coming from the posterior descending artery. Single blood supply, single blood supply. That's why posteromedial papillary muscle is the one that's going to usually blow out. And the usual MI, the most common cause will be an inferior MI, right? Not anterior MI, because the RCA is the one that's going to supply the PDA, posterior descending artery. We have discussed so many times in our regular lectures, right? So this is the reason. So three important reasons: leaflet problem, or it could be chordae problem, or it could be papillary muscle defect. Any of this can produce MR. So etiology of MR will be little complex, but apart from that, it's not like completely non-understandable. So what is the hemodynamics? If you want to write in one single sentence, here the problem is increased left atrial volume rather. Okay. In MS, the main problem is increased left atrial pressure, and that subsequently increases the left atrial volume. But here the main problem is increased left atrial volume, and of course, increased left atrial pressure as well. But the most important problem is increased left atrial volume. Because during systole, the blood moves not only into aorta, the blood moves into atrium as well. Left atrium also gets a lot of blood during systole, which normally it should not get. And that's why the left atrial volume and pressure increases dramatically. And apart from that, you're going to have the same hemodynamics. Okay, because of the increased left atrial volume and increased left atrial pressure, you're going to have increased pulmonary venous pressures. And because the pulmonary vein struggle to empty blood into the left atrium, your pulmonary congestion occurs, and that can result in crepitations, shortness of breath, and pulmonary edema. And if the pulmonary pressures are chronically high, it can result in reactive vascular changes, resulting in pulmonary hypertension and subsequent right ventricular failure. But MS is a well-tolerated lesion. Why? So MR is a well-tolerated lesion. Sorry, MR is a well-tolerated lesion. Why? Because in MS, the stenosis is always there. So whether the left ventricle is in systole or diastole, whatever may be the cardiac cycle, the stenosis is always there throughout the cardiac cycle. But in MR, the event occurs only during systole, or it occurs during both systole and diastole? Tell me. In MS, the stenosis is always there throughout the cardiac cycle. But in MR, the event occurs only during systole. It doesn't occur during diastole. So what happens is over time, the left atrium starts adapting to that excessive flows. So if the left atrium doesn't expand during systole, that's where the problem is. That occurs in acute MR. I'm not going to talk about that right now. But in a chronic MR, what happens is, as the blood comes from the left ventricle, the left atrium keeps expanding like a balloon. So what happens in chronic MR? During systole, the jet comes up, the left atrium expands nicely. So then the left atrium comes back to normal size. Then left atrium expands. Then left atrium will come back to normal size. LA, expand, come back. So what happens in chronic patients? The left atrium is going to become more compliant. Once the left atrium becomes more compliant, the pressure will not rise that much. Remember, if you are compliant to something, you don't get pressurized. If you're non-compliant to something, you feel a lot of pressure. That's what is going to occur. In a chronic MR, because of a good LA compliance, because it can end large, the pressures will not rise. That's the reason patients usually don't develop pulmonary edema when it comes to chronic MR that easily. It takes a long time for the patient to develop a pulmonary edema and pulmonary hypertension in patients with chronic MR. That's why it's one of the very well-tolerated valvular heart disease. And tell me, so in MR, so let me draw this diagram again. So here is the mitral valve, here's the left atrium and the left ventricle. In MR, what happens? During systole, the blood goes into the left atrium. Because of the mitral valve problem, the blood goes into the left atrium. And whatever blood that goes in the left atrium, during diastole, it has to come back into the left ventricle, right? During diastole, it has to come back to the left ventricle. So tell me here, the LV is receiving more blood or less blood during diastole? So it's receiving blood that is already there in the left atrium, plus whatever it's pushed into the left atrium is also coming back during diastole. So LV is receiving more blood. So here the LV is pressure overloaded or volume overloaded. If you have more quantity of blood, what do you think? It's here the LV is volume overloaded or pressure overloaded? So you're going to have LV volume overload, not pressure overload. So tell me, whenever you are volume overloaded, you're going to dilate. LV is going to dilate here. And the dilatation can be massive. LV dilatation. And this LV dilatation is going to displace the apex, or the apex will be non-displaced. Tell me fast. Apex will be displaced or non-displaced? Apex will be 100% displaced. There is no doubt about that. The apex is going to be displaced. Which means there's going to be a down and out apex, because whenever LV is displaced, the classic displacement is going to be down and out. That is something that you have to memorize. There is no other option. Down and out displacement of apex. And in volume overload, you will commonly get third heart sound or you will not get third heart sound. I told you, one of the main reasons for third heart sound is LV, is volume overload of LV or RV for that matters. So you're going to get LV third heart sound. Third heart sound is very, very common, extremely common in the setting of MR. And remember, in a non-failing heart, according to Frank-Starling law, if you receive more volume, you have to contract more or you have to contract less. The stroke volume will increase or decrease. Contract more or contract less? Yes, because of increased end diastolic volume, this LV will be a hyperdynamic LV. The nature of the apical impulse will be hyperdynamic. You're going to have a hyperdynamic left ventricular apex, and the LV will be hyperdynamic. And this hyperdynamicity is important. And the LV has to contract harder. And it is a must. Can you tell me why? Why it is a must? Why LV has to contract in a hyperdynamic fashion? That is because here LV has two orifices. One towards the aorta, another abnormal backflow into the left atrium. So to compensate for that backflow into the left atrium, LV has to contract harder to put at least some blood into the aorta. Do you understand why that hyperdynamicity is required? If you lose that hyperdynamicity, you will end up with heart failure. You have to have hyperdynamicity because you have to somehow push enough blood into aorta. For that, you need that hyperdynamicity. So that's why in your mitral regurgitation, ejection fraction will almost always be higher. In fact, it will be very high. EF will be extremely high, but you should not get fooled by that. So what is ejection fraction? Ejection fraction is equal to stroke volume by end diastolic volume, right? What is technically stroke volume? How will you calculate stroke volume? Simple. It is end diastolic volume minus end systolic volume divided by stroke volume. So remember, the end diastolic volume in MR is very high, right? And the end systolic volume will be very low because of the hyperdynamic LV, because the LV is pushing a lot of blood. But only a part of blood is going into aorta. Some part is going back into the left atrium. So that's the reason why the end systolic volume will be very low. LV will be small at the end of the systole. But during the end of the diastole, LV will be huge because a lot of blood is coming from left atrium back into LV. So do you think stroke volume will be more or stroke volume will be less? Tell me, stroke volume will be more or less in these patients? Mahima is telling less. How is it possible? Your EDV is high, ESV is low. So difference is going to be very high, huge. So, sorry, here it is end diastolic volume. Sorry, I made a mistake over here. Sorry, it's end diastolic volume over here. So you can notice clearly that EF is going to increase dramatically. That is the reason why in patients with mitral regurgitation, your EF is going to be like 70, 80% sometimes. Normally somewhere around like 55 to 65, whatever. But in MR, you're going to have an EF of 70, 80% sometimes. And that EF of 70, 80% in MR is equivalent to normal EF, like 50, 55%, like you and me. If you clearly think about it, not all that is coming into aorta. A portion only is coming into aorta. Remaining is going back to the left atrium. So that high ejection fraction is like a kind of a normal EF only for those patients with MR. Do you understand this? Yes or no? I'll tell you where it is going to be useful. Yes, so that hyperdynamicity of the left ventricle and the high ejection fraction is important for MR patients because only a portion of the blood is going into aorta. Remaining is going back to the left atrium. So that's the reason. Your high EF and hyperdensity of the heart is essentially, if it's lost, you'll end up with heart failure. So EF of 70, 80% in MR is basically equivalent to an EF of like 55 or 60% in normal individuals. So you should not get fooled by that. And coming to the presentation, how these patients are going to present, the most common presentation that most of the patients are going to tell is like palpitation. That's the usual presentation. That's the usual thing that most of them are going to tell. So they're going to tell palpitations because of why palpitation is because of hyperdynamic LV, because LV is literally pounding here, literally contracting so hard. So we're going to get palpitation. It's actually not because of atrial fibrillation. You have to be very clear. Atrial fibrillation can develop, but most of the cases, the palpitation will be just due to like hyperdynamic LV, like pounding like anything, contracting harder. That's the reason for palpitations. And because aortic blood flow is not that great in MR, you're going to have fatigue, low cardiac output symptoms. Patients start developing fatigue, especially exertional fatigue, slowly, if the LV fails, because they cannot keep on contracting for a long period of time. At one point, they're going to get broken down, the LV will fail. And once LV starts failing, you're going to get shortness of breath, you're going to get pulmonary edema. And this shortness of breath is basically because of pulmonary congestion. And they can develop frank pulmonary edema. And once the left atrial pressures and the pulmonary artery pressures keeps increasing, problems will keep compounding. And in late stages, patients are going to develop pulmonary hypertension, just like in MS. And they can develop even right ventricular failure, but that's very, very late. In MS, it can occur at any time, but in MR, it's going to be late. So why aorta is getting less flown? I mean, there is volume overload, so LV and aorta should get enough blood. But I'm telling, the reason why aorta is getting less blood is because of heart failure over a period of time. Initially, the aortic blood flow will be maintained because of the hyperdynamicity of the left ventricle. Even though some of the blood is going back into the left atrium, because of the hyperdynamic LV, because it contracts harder and faster, somehow it will maintain the aortic blood flow. But you cannot keep on pounding like that for a long period of time. At one point of time, you will get tired and the LV will fail. At that point, once the hyperdynamicity comes down, that is where the problem starts. So can you explain the EF again? Yes, why not? So I told you already, EF is nothing but stroke volume by end diastolic volume. Stroke volume is defined as end diastolic volume minus end systolic volume. So here EDV will be higher because a lot of blood is coming from left atrium. And end systolic volume will be lower. That is because of hyperdynamic left ventricle. So because the EDV is high, ESV is low, in usual MR, your stroke volume is going to be very high. Because stroke volume is high, the ejection fraction will increase like anything. So you should not get fooled by that high ejection fraction, because that doesn't tell you the heart is actually doing good. In fact, that high ejection fraction and hyperdynamic heart is required to maintain at least a normal aortic blood flow. If that hyperdynamicity is lost, if ejection fraction comes down even slightly from a higher value, it means the heart is failing. That's it. What is late presentation? Once the patient has a very chronic MR, so in late stages, they start developing pulmonary hypertension and right ventricular failure. Patient starts developing pulmonary hypertension and right heart failure. So that's what you mean by late presentation. Okay, somebody's asked the doubt. And of course, patients are at risk of developing atrial fibrillation because of left atrial enlargement. Patients can develop atrial fibrillation as well. So because of left atrial enlargement, of course, patients can develop AF. All right, so what are the clinical examination findings when it comes to MR? So what about the pulse? Pulse will be hyperkinetic in nature. Pulse will be hyperkinetic in nature, and they will generally tend to have a normal volume pulse only, even though many people tell that MR patients will have a large volume pulse, but technically it's not. They don't have a large volume pulse, they'll have a normal volume pulse only. You can understand why. Why hyperkinetic? Hyperkinetic means the rise will be rapid. So you can see kind of a like faster rise because of the faster contraction of left ventricle. But remember, some of the blood is going back into the left atrium, not coming into the aorta. So that hyperdynamicity is actually causing a normal flow into the aorta. That's why you're going to have a normal volume. Are you understanding why normal volume? Yes or no? You're not going to have high volume pulse. You're not going to have a large volume pulse. You're only going to have a normal volume pulse. And that is especially because even though the ventricle is hyperdynamic, the hyperdynamicity is to maintain the normal flow in the aorta. It cannot produce excessive flows because some of the blood is going back into the LA. So normal volume pulse. What about the JVP? Typically normal. Only if the patient develops pulmonary hypertension, the JVP will increase. You can see large A wave. Only if the patient develops atrial fibrillation, you're going to have absent A wave. Otherwise, the JVP will be normal because this is a typical left-sided problem. What about the apical impulse? Apical impulse, definitely hyperdynamic. We have discussed that already. The nature of the apical impulse will be hyperdynamic, plus it will be displaced. It will be displaced, and you're going to have a down and out apical impulse. You're going to have a down and out apical impulse. What about first and the second heart sound? S1 will be typically soft. This is a rule in MR. S1 will be soft because the valve is not coapting at all properly. It's not heating properly at all. It's just flabby. So you have to get a soft S1. That's a rule. And S2, intensity-wise, it will be normal. But split is very, very important. Split is very important. So you're going to have a wide split. That's very, very important point. So normal split of S2, it is like this, A2, P2, right? Normal split of S2. But in a patient who's having a severe MR, let us assume the heart is failing. The amount of blood to the aorta will come down or it will increase. If the heart starts to fail, the amount of blood to aorta will increase or decrease. The amount of blood flowing to aorta will increase. So the aortic valve will close faster. My God, if the heart is failing, the blood flow to the aorta will increase. My God. Amount of blood flow to aorta will decrease, right? So what will happen to the aortic valve closure? It will close early or it's going to close late. If the blood flow is reduced, it's going to close early or it's going to close late. I don't know why some students are answering late. If the blood flow is less, obviously it has to close early. It cannot close late. So if it's going to close early, what will be the split? It will become wide or narrow. Because of early closure of A2, you're going to have wide split or narrow split. Of course, you're going to have wide split. So whenever you have a wide split, it indicates high severity, which means the heart has already started to fail. The LV is not able to maintain sufficient flows into the aorta. That's why the aortic valve closes faster, early A2 resulting in a wide split. What about the extra sounds? Do you get any extra sounds? Yes, sometimes you can hear third heart sound. Very, very common. Third heart sound is very, very common. But in case, if they ask you, can you hear fourth heart sound in MR? What will you answer? This is not a tricky question, a straightforward question. Can you hear a fourth heart sound? Yes, but where? No, you can hear. Where? Only in one condition that's very important, in acute MR. Okay. If the MR is acute, you're going to hear fourth heart sound. I told you the logic for third heart sound. The logic for third heart sound is very simple. It is volume overload of the left ventricle. Can you tell me what is the logic for fourth heart sound? The rationale for fourth heart sound is a stiff ventricle. I'll repeat, a non-compliant stiff ventricle will result in fourth heart sound. Whenever your atrial contraction occurs against a stiff left ventricle or right ventricle, it's going to produce fourth heart sound. In acute MR, I mean, leave the chronic. In chronic, I told you things will become compliant. But in acute MR, you think LV will be compliant or LV will be non-compliant. In acute conditions, both LA as well as LV will be non-compliant. So if a lot of blood is coming from left atrium into a non-compliant ventricle, that is going to produce fourth heart sound. So in acute AR or acute MR, that's where you're going to have fourth heart sound. Otherwise, in a chronic MR or a chronic AR, you're going to have only third heart sound because of volume overload of the left ventricle. Are you understanding? S4 is because of atrial contraction against a stiff non-compliant ventricle. Because in acute MR, LV will be non-compliant and a lot of blood is coming from left atrium. And because LV is stiff, it's going to produce fourth heart sound. So this is a very important point. If you see S4 in an MR, in exam, you always make a diagnosis of acute MR. What about the murmurs? So classic murmur is a pansystolic murmur in a chronic MR, but it can differ depending on the situation. But in a classic chronic MR, you're going to have a pansystolic murmur typically heard in apex, and it's a kind of a blowing and a high-pitched murmur. The classic description is blowing, high-pitched murmur. And this will be heard best with the diaphragm of the cell because it's a high-pitched murmur. It will be heard better with the diaphragm of the cell scope. And because it's a left-sided event, the murmur will increase with expiration. And because it's a mitral murmur, it will be best heard with left lateral position. Because it's a mitral murmur, you're going to hear this murmur better in the left lateral position. A very, very important point, left lateral position. And what is the differential diagnosis for pansystolic murmur? In exam, only two important DDs. One is TR murmur and second is VSD murmur. You all know TR murmur is going to increase with inspiration because it's a right-sided event. And it will be best heard in the left lower sternal border. And often the jugular venous pressure will be very high and you're going to have a large V wave. But in a pure MR, generally the jugular venous pressure will be normal unless until patient develops pulmonary hypertension. But in TR, often JVP will be very high. In severe TR, you're going to see a very large V wave. And there will be absent X descent. X descent obliteration is characteristic feature of severe TR. And VSD is going to increase with expiration, just like your MR murmur, but it will be heard in the left lower sternal border. And again, JVP will be normal in a classic VSD unless until patient is having pulmonary hypertension. So the two important DDs for a pansystolic murmur for MR will be TR and VSD. TR murmur will be heard best in the left lower sternal border. It increases with inspiration and JVP will be increased. VSD murmur will be again heard in the left lower sternal border only, but it increases with expiration because the blood flow moves from LV to RV. And JVP will be classically normal unless and until the patient develops pulmonary hypertension. So that's about the VSD murmur. Sorry, guys. All right. So, yeah, we have discussed about the differential diagnosis of the pansystolic murmur as well. And now let us look at the hemodynamic diagram. So if you look at this, you will understand things better. So normally during systole and diastole, so you should have like kind of a good pressure gradient between LA and LV. So if you look at this one, so you'll understand things better. So this is a MS diagram. You can notice that the LA and LV pressures has to be like grossly different during systole, because during systole, the mitral valve should close. The mitral valve closes properly. There should be a huge gradient between LV and LA. But if you look at MR, the gradient is lost. I'll not say it's lost, but the gradient is decreasing. And you can say the increase in the LA pressure during MR. So this is the most important event, increase in the LA pressure during systole. And generally, you're going to see a large V wave. In TR, you're going to see a large V wave in the JVP. Likewise, in MR, you're going to see a large V wave in the left atrial pressure tracings. So what is going to tell you the left atrial pressure? It is the pulmonary capillary wedge pressure. If ask you how to find out the left atrial pressure, the indirect way to find out left atrial pressure is pulmonary capillary wedge pressure. And in PCWP, you're going to see a large V wave. So which is a sign of a MR. Very, very important point, a large V wave. And most of the time, you're not going to have X descent just like your TR. In TR also, you don't have X descent. In MR also, you don't have X descent in left atrial pressure tracings. And there will be a C wave and V wave fusion. In severe MR, you're going to have a CV fusion. Normally, the blood should not flow into the left atrium during systole. But here, the blood flows into the left atrium during systole. And that creates a turbulence, which is going to produce the classic pansystolic murmur. That's going to produce the classic pansystolic murmur. Are you understanding this? Yes or no? It's simple. It's not very difficult. Because blood moves into the systole. Because the blood moves into the left ventricle during systole, you're going to have a turbulence during the blood flow into the left atrium during systole, and that's going to produce the pansystolic murmur because the blood throughout your LV systole is going to move into the left atrium because LA pressures are always low. The mitral valve is the one that prevents the movement of blood normally. It's leaky here. So blood is going to flow throughout from LV to LA. What about V wave and A wave? So A wave is normal here. Unless and until pulmonary hypertension is there, you're not going to have any problem in the A wave. But during the C wave only, your ventricular contraction typically starts. From there, the blood keeps moving into the left atrium, and that's going to produce a large V wave. So there will be obliteration of the X descent, no X descent, just like your TR, and there will be movement of blood from LV to LA, and that's going to increase the pressure. So the V wave will be very, very big. So in TR also, your V wave will be big. In MR also, your V wave is also going to be. It depends on where you are measuring the pressure. That's all. If you're measuring the right atrial pressure, you're going to have large V wave in TR. If you're measuring the left atrial pressure, you're going to have a large wave in MR. That's all. As simple as that. Okay. And before assessing the severity, let me tell you the concept behind this assessment of severity. That's very important in echo. So for that, you have to understand the concept of a sink. So whenever you are lying in a sink, maybe in a jacuzzi, let us assume. So you are lying in this thing. And when you accumulate water and you suddenly remove the plug, so what happens? Can you see the whirl near that opening? Have you ever noticed that? Have you ever noticed that whirl near that opening of that pool? Whenever you suddenly open the orifice, you start noticing that whirl, right? Everyone would have noticed. So the regurgitation is also something similar to that. So what happens is, let us assume this is left ventricle and this is left atrium. So what really happens is, just imagine the sink. So once you open the plug, it's going to create something called as flow convergence. That's the whirl that you're seeing. That's what we call as flow convergence. And according to physics, once the fluid or gas flows across that orifice, it's going to create the narrowest portion. It's going to create the most narrowest portion of the flow that is called as vena contracta. It is the most narrowest portion of the flow. And by default, it's going to have the maximum velocity. At that point only, you have the maximum velocity because I told you the most narrowest point only, you're going to have increased velocity. So maximum velocity. And then the jet will splash into the respective chamber, whatever chamber it is, into the regurgitant chamber. And based on what is the jet area and based on what is the jet length also, to some extent, you will be able to tell the severity. So what we are going to notice is the vena contracta. The smaller the vena contracta is, the larger the vena contracta is, more is the severity. And if the jet length and jet area is more, again, you're going to tell that the patient is going to have more severity. Let us have a look at this real-time echo image. Here is the left ventricle and here is the left atrium. You can notice beautifully that the blood is moving from LV to LA in MR. And you can notice the flow convergence over here. You can notice the narrowest portion, that is the vena contracta. And you can notice the jet moving into the left atrium. You can notice the jet width as well as the jet area as well as the jet length, all can be used as markers of severity. Are you understanding or not? Yes or no? So now we can understand what do you mean by flow convergence, what do you mean by vena contracta, what do you mean by jet area, what do you mean by jet length. All these things can be picked up in echocardiogram, pretty much simple and straightforward. That's all. And I don't know how much relevant for you is the Carpentier classification. So Carpentier classification has 4 types of MR: type 1, type 2, type 3, and type 3 and type 3B MR. In type 1, the leaflet motion and position will be normal, but the problem is some perforation or cleft in the leaflet. So that's what is going to occur. So that is Carpentier type 1. In type 2, there will be excessive leaflet motion. That is because of the redundant chordae tendineae, typically occurs in mitral valve prolapse. In Carpentier type 3, you have 3A and 3B. In 3A, you're going to have restricted leaflet motion in both systole and diastole. In Carpentier type 3B, you're going to have restricted leaflet motion in systole only. The classic example of Carpentier type 3A MR is rheumatic heart disease. Because of thickening of the mitral valve, there will be restricted motion of leaflet in both systole and diastole. Other examples include mitral annular calcification and drug-induced MR, but the classic example is rheumatic heart disease. So type 1, leaflet perforation. Type 2, mitral valve prolapse. Type 3, rheumatic heart disease. And we have something called secondary MR also. So if they talk about ischemic cardiomyopathy, okay, that is probably, for example, a DCM or anything else. Especially like in ischemic cardiomyopathy, you are going to get restricted leaflet motion only during systole. That is often referred to as Carpentier type 3B. And the non-ischemic cardiomyopathy and atrial MR will come under Carpentier type 1. So I don't really know how much important is this. Maybe they can ask in the future exams, but this is given in Harrison. That's why I've mentioned this. So what you need to know is type 1, normal leaflet motion and position. Still, because of some perforation in the leaflet, you get MR. In type 2, there will be excessive leaflet motion. The best example, mitral valve prolapse, where there will be redundant chordae because of that excessive leaflet motion. In type 3, there will be restricted leaflet motion. Type 3A, restricted leaflet motion in both systole and diastole. In type 3B, there will be restricted leaflet motion only in systole, but not in diastole. That's it. So after understanding the important basic physics behind regurgitation, now we can assess the severity. So I told you, so the color jet filling LA. So if the jet fills so much of LA, it's going to indicate high severity or low severity. If the MR jet fills almost the entire LA, it indicates high severity or low severity. Of course, it's going to indicate high severity. If you have understood the concept, just give some numbers. So I can say if it fills more than 40% of left atrium, I can say it is severe MR. If it fills less than 20% of left atrium, it indicates a mild MR. So vena contracta, I said the narrowest portion of the jet is vena contracta. If the narrowest portion itself is like more, you think the severity is more or severity is less? Narrowest portion of the jet itself is more wider, means severity is more or less? Severity has to be more, that's all. So just give some numbers to it. If the narrowest portion of the jet itself is very large, more than 0.7 centimeter, it indicates a severe MR. If it's less than 0.3 centimeter, it indicates a mild MR. That's all. So regurgitant volume, simple. More the regurgitant volume, more is the severity. By definition, more than 60 ml per beat. Every beat, if there is more than 60 ml of blood flowing into left atrium, high severity. Less than 30 ml per beat, low severity, mild disease. Then we have something called regurgitant fraction. You know, some part of the LV blood goes into aorta and some part of the LV blood goes into left atrium. So what is the proportion of LV blood going into left atrium? That's called regurgitant fraction. If more than 50% of the LV blood during systole, if it goes into the left atrium, that's bad. More than half of the blood is going into the left atrium only, not into the aorta. And when you call it as mild MR? Less than 30%. Then we have something called regurgitant orifice area. So across what area the regurgitation is occurring? Again, if it's more than 0.4 centimeter square, it's going to indicate high severity. And if it's going to be less than 0.2 centimeter square, it indicates mild disease only. So what is important for exams is this only. This is what is going to be the most important for exams. See, the numbers you can mug up anytime, but are you understanding the concept behind it? Yes or no? The numbers you can mug it up. Later on, you go home and you can mug it up, no issues. But the concept is what is going to stand with you for long. So, are you understanding? Yes or no? I'm expecting some answers. So, color jet filling left atrium, vena contracta, regurgitant volume, regurgitant fraction, regurgitant orifice area. So, all of these things, if it's going to be high, it indicates high severity. So what are the indications for surgery, by the way? I told you only 2 rules. The same rules apply here also. Number 1, symptomatic severe MR. That's all. Class 1 recommendation, straightforward, symptomatic severe MR. Number 2, patients can have asymptomatic disease. Plus they can have severe MR, provided if they have some complications due to MR. So what are the complications due to MR? Anyone wants to answer? What are the complications? What are the complications due to MR? Who's going to tell me the complications due to MR? Same like your MS, new atrial fibrillation. Same like your MR, MS, new atrial fibrillation. And second is severe pulmonary hypertension. I already told you for MS. What is the definition of severe pulmonary hypertension? Please tell me. You're going to answer because if you're listening, you should be able to answer. If the pulmonary artery systolic pressure is more than 50 millimeters of mercury, I told you already, at rest. Or what is the excess cutoff? You're going to tell the excess cutoff, beyond which you're going to call it a severe pulmonary hypertension. Yes, of course, if it's going to be more than 60 millimeters of mercury with exercise, you're going to call it a severe MR. Severe pulmonary hypertension. So same, but MR patients also develop some additional problem apart from MS. In MS, LV never fails. But in MR, LV fails or LV never fails in MR? In MS, LV never fails. In MR, LV fails or it doesn't fail? It fails. So you have to look at ejection fraction. You have to look at ejection fraction. If it's less than 60%, if the EF is less than 60%, it's abnormal. It's bad. It indicates LV is failing. See, if I'm having an EF of 55%, I'm okay with that. I told you in MR, you cannot have a normal EF. The high EF is the new normal. Even if the EF slightly goes below 60%, it is as equivalent to an EF of like around 30-40% in a patient who's not having MR. Because in MR, you should have a high EF. Then only you can maintain a good aortic flow. Once the EF, even if it becomes normal, it's going to collapse the patient. It's going to decompensate the patient. That's why EF less than 60%, a very important indication for surgery, even if the patient is asymptomatic. Or alternatively, if the patient is having a huge left ventricle, huge left ventricle. Normally, the left ventricle in MR dilates during diastole or systole. Tell me. Normally, the left ventricle in MR dilates during systole or diastole. Dilates during systole or diastole? No. So where in MR your LV is going to dilate in systole? It's going to dilate in diastole. See, during diastole only you get blood from LA. That's the time a lot of blood is going to come from LA into LV. So the LV is going to expand during diastole. During systole, it's contracting harder. In fact, it's collapsing harder during systole. It's contracting so much. It's pounding. So the end systolic diameter will be usually small in MR. But if the end systolic diameter is increasing, if it becomes more than 40 millimeter by definition, this is clearly indicating that the LV is not contracting harder. If the LV stops contracting harder, you will result in hemodynamic collapse. You will result in hemodynamic decompensation. That's the reason why end systolic diameter, if it becomes more than 40 mm, this is also an indication for surgery. So very simple. Again, our common principles apply here as well. Symptomatic severe MR, asymptomatic severe MR, provided if you have some complications like new EF for severe pulmonary hypertension. Plus in MR, I'm going to add additionally heart failure component where EF less than 60% or ESD more than 40 millimeter. Are you understanding or not? Very simple. At least the concepts. Are you understanding? Numbers you can mug up later on. No issues. Yes or no? Yes, right? Fine. Cool. Now let us move on to aortic stenosis. And we have only like two simple valvular heart disease. One is aortic stenosis, by default, one of the most common valvular heart disease in the world right now. So what is the etiology for aortic stenosis? Like only two etiologies basically. One occurs in old age and another occurs in young age. These are the two most important etiologies. So in old age, which is the most common form of AS, it's going to be calcific aortic stenosis, as simple as that. It's one of the most common forms of aortic stenosis, calcific aortic stenosis. And number two, in young patients, you're going to have aortic stenosis, and that is typically because of bicuspid aortic valve. Okay, in young patients, you can have aortic stenosis, but typically it's going to be because of bicuspid aortic valve. Right? Apart from that, very rarely, rheumatic heart disease can produce aortic stenosis, but this is not at all common. Rheumatic heart disease can produce MS, MR, AR also, but AS is extremely rare with rheumatic heart disease. So only two important causes. In old patients, think about calcific AS. In young patients, think about bicuspid aortic valve. That's all. And remember, bicuspid aortic valve can produce AS as well as AR, and patients can have both together also. So don't think bicuspid aortic valve is going to produce only AS. It can produce AS, AR, or even both together. And what you're going to get in aortic stenosis as a part of hemodynamics, very simple. You're going to have a stenosed aortic valve here. So because of stenosed valve, the pressures are going to increase in the LV, but pressures in the aorta are going to drop, because that's a common rule across any obstruction or stenosis. The proximal pressures are going to increase, the distal pressures are going to drop. So left ventricle is undergoing pressure overload or volume overload. Just tell me, left ventricle is undergoing pressure overload or volume overload here? I'm not getting answers faster. So there is no volume overload here. Predominant problem that is occurring is pressure overload. So because of increased LV pressure, you're going to result in severe left ventricular hypertrophy. Severe left ventricular hypertrophy, the muscles are going to get bigger. Hypertrophied muscles, thick muscles, severe LVH, severe left ventricular hypertrophy. And because of severe LVH, the left ventricle becomes very stiff. LV becomes very stiff. It cannot dilate that. It cannot relax that easily during diastole. If the LV becomes very stiff, I told you stiff LV will result in what heart sound? Third heart sound or fourth heart sound? Volume overload of LV, third heart sound. That's why S4 is very, very common. Once you develop S3, it means the patient is actually having a severe left ventricular failure. That is different. You can get S3 over there, but S4 is the commonest heart sound that is in patients with aortic stenosis. And because of increased LV pressures and because of reduced LA complex, because the LV becomes stiff, your blood from LA also will not flow into LV that easily, because LV is not ready to get all of that blood from left atrium because the LV becomes very stiff. So there will be slowly left atrial enlargement over a period of time. One of the important causes of left atrial enlargement, not just MS, not just MR, even AS can result in left atrial enlargement just because the LV is not able to receive enough blood from left atrium. Blood accumulate in the left ventricle. Does it lead to volume overload also? No. It's actually pressure overload only. So ventricle thickens basically. The ventricle will become thick. It's basically a pressure overload condition. Where the extra volume is coming from? It has to come from LA only, right? So if the ventricle becomes stiff and stiff over time, where the blood will move from LA to LV. So it's basically pressure overload. If the ventricle starts developing volume overload, it indicates a heart failure. It indicates a left ventricular failure. So it's a very, very basic concept. And because the patient is having severe LVH and the muscles are very, very strong, the punching power will be strong or punching power is going to be weak. This ventricle's punching power will be strong or weak because it has so much of muscle. So it's going to be strong. So it's going to produce apical impulse for a longer duration or lesser duration. It's going to contract for a longer time or lesser time. So it's going to contract longer. It's going to contract for a longer time. If it's going to contract for a longer time, what is that called as? What is the type of apical impulse called as? Sustained contraction, longer duration of contraction of apical impulse. It's called as heaving apical impulse. Okay, that's called as heaving apical impulse. And what about the cardiac output? The pressure is increasing in the LV, but the pressure is simultaneously dropping in the aorta. So what the patient will have, lower cardiac output or increased cardiac output. Patient is going to have lower cardiac output. So that's the reason for syncope, angina, and so many other problems. So this is the hemodynamics. In one word, if you want to say hemodynamics, it's increased LV pressure. That's it. That's the most important element when it comes to aortic stenosis. And simultaneously, the aortic pressures are going to drop. So what about the presentation? Many people know, they call it as SAD, but I used to remember the mnemonic of ASD. So A stands first. So no, it's not SAD, it's basically ASD triad. So you have to remember in that order. Syncope doesn't occur first, it's actually angina first. Angina occurs first. Typically in exertional angina, over time they start developing resting angina. Second manifestation is the syncope. And finally, last manifestation is dyspnea. So this is the ASD triad. So remember, the symptoms of AS strongly correlate with the prognosis, strongly correlate with the survival. We call it as 5-3-2 rule. It's called as 5-3-2 rule. Once angina develops, the median survival is 5 years if you don't treat them. Once the patient starts developing syncope, the median survival is 3 years if you don't treat them. Once you develop dyspnea, the median survival is 1 year if you don't treat them. So this is the average survival. This is called as ASD 5-3-2 rule. I repeat, this is called as ASD 5-3-2. Sorry, it's not 1 year, it's 2 years. So it's called as ASD 5-3-2 rule. Very important. So presence of symptoms itself is a poor prognostic sign in patients with AS. What will be the pulse? Of course, it's a stenotic orifice. The cardiac output is low, so the pulse is going to be hypokinetic. There is no doubt about that. It's going to be a small volume pulse, small volume and hypokinetic pulse. So what is the special name given to that small volume pulse in AS? So in Latin, you have parvus magnus, which is small. Parvus is small or magnus is small? Parvus is small or magnus is small? Of course, yes. In AS, you're going to have something called as pulsus parvus, small. Pulsus parvus. It's a small pulse. And what about the peak? Peak will be retarded, small peak, or peak will be big in AS. Small pulse, but peak will be retarded or peak will be big. Small or big. Of course, because of the stenotic, because the stenotic orifice, you're not going to have a big peak. The peak will be small, diminished, retarded. That's why it's called as parvus attardus. So small pulse, small peak, and a delayed peak. Classic pulses parvus attardus. Okay, small and hypokinetic pulse. And what about the jugular venous pressure? Of course, it will be normal. There is something called Burnham effect, but at an undergrad level, it's not that important. So JVP will be typically normal in AS because it's a left-sided problem. To get pulmonary hypertension AS is very, very rare. Patient will die before that. So can you repeat pulse? Yes, of course. So it's a small pulse because you're having obstruction, man. Across obstruction, like you will have a low pressure. You're not going to have a good flow of blood outside of this obstruction. So the pulse volume as well as the pulse peak will be diminished. It will be small. And if you have obstruction, you can reach the peak easily or you're going to reach the peak very slowly. You're going to reach the peak easily or very fast, or you're going to reach the peak very slowly. You're going to reach the peak very, very slowly over a period of time. And that's why in exams, they will mention something called as delayed carotid pulse. Delaying of carotid pulse. Are you understanding why delayed carotid pulse? Yes or no? So why the pulse is hypokinetic? Why it is called as parvus attardus? Why delayed carotid pulse? So how will you find out that the carotid pulse is delayed? So you simultaneously hear the heartbeat and palpate the carotid pulse. Simultaneously heartbeat and the carotid pulse. So the heartbeat will come, but in most cases, the carotid pulse will follow very shortly. But if the heartbeat has come and after a long time only, if you are feeling the carotid pulse, that is delaying of carotid pulse. That's characteristic of AS. And they will have a delayed peak. Everything will be delayed, slow, delayed, and small. What about apical impulse? Apical impulse, I told you already. The character of the apical impulse will be heaving. Heaving type of apical impulse, which is nothing but a sustained and a forcible apical impulse. Yes, sustained and a forcible apical impulse because of high LV pressures. But location will be normal. That's very, very important because it's a LV pressure overload. Only the muscle is thickening. You will not have displacement of the apical impulse. Location will be normal, which means it will be non-displaced. Only a volume overloaded left ventricle will be showing a displaced apical impulse. Yeah, I mean, double or triple apical impulse in exam always goes towards HOCM, hypertrophic obstructive cardiomyopathy. That's because of a completely different concept. In HOCM, you're going to have a kind of a dynamic obstruction. But in aortic stenosis, you're going to have a fixed LVOT obstruction. In fact, this is the very, very basic hemodynamic data. In patients with aortic stenosis, you're going to have something called as fixed LVOT obstruction. But in patients with HOCM, you're going to have a dynamic LVOT obstruction. That's the reason for so many other interesting features like Bispherian's pulse, double apical impulse, or even triple apical impulse, and so on. But here you don't see that. What about S1 and S2? First heart zone, second heart zone. First heart zone, technically normal. You won't have any much problem with the first heart zone when it comes to AS. But second heart zone has two components, right? So what about A2 component? If the valve is calcified, of course, sound will be soft or sound will be loud. You can answer yourself, right? If the valve is calcified, which is the usual reason for development of AS, the sound will be soft or sound will be loud. Yes, of course, the sound will be soft. And when it comes to S2, of course, you need to definitely talk about the splitting of the second heart zone. Splitting is normally, let us assume it is A2 and P2. Here, the ventricle is very powerful. Here, the ventricle is very powerful. It's going to contract for a longer time or lesser time. Ventricle is powerful. It's going to contract for longer time or lesser time. And there is no. Ventricle is very powerful. Ventricle is very, very powerful. It's going to contract for a longer period of time. So if it contracts for a longer period of time, you're going to have a late A2. The A2 becomes what? Late. So what happens? You'll get a narrow split or a wide split. You're going to get a narrow split or a wide split. Yes, of course, you're going to get a narrow split. Or in case of very late A2, what happens? It goes beyond P2 and you're going to have a split like this. What is this called as? If P2 comes first and A2 comes later, this is called as reverse split or otherwise called as paradoxical split. If you're gonna see reverse splitting or narrow splitting, that indicates high severity. Am I true or not? Because the obstruction is so severe that the ventricle is literally struggling to push the blood against that obstruction. It's contracting for a long period of time. So that's why I can say the severity is going to be higher if you have a narrow split or a reverse split. Do you understand? Yes. Cool. Now, what are the extra sounds? The most important extra sound in aortic stenosis is going to be the ejection click, the valvular ejection click. And this is typically seen, most commonly seen in patients with bicuspid aortic valve, a very, very important point. Remember, in calcific AS, because the valve is completely calcified, you don't really see any ejection click. Most of the times, you don't see it. But in bicuspid aortic valve, in early stages, the valve will be pliable. Even though it's tenos, the valve will be still pliable. So if it opens, it can produce a nice, good ejection click. I told you, when cerebellar valves open and if it produces a sound, that's called as ejection clicks. When your atrioventricular valves open and if it produces a sound, it's called as opening snaps. So what is the importance and significance of this ejection click? Because when it comes to your aortic or pulmonary stenosis, there are three levels of stenosis: supravalvular, valvular, subvalvular. I'll repeat, both pulmonic stenosis and aortic stenosis has three levels of stenosis: supra, valvular, valvular, and subvalvular. If I'm hearing a valvular ejection click, you can 100% say that the problem is at the valvular level only. I can completely rule out supravalvular and subvalvular AS. Are you understanding or not? That's the significance of this ejection click. If I'm hearing a valvular ejection click, which means the problem has to be at the valvular level, that completely rules out my supravalvular as well as subvalvular causes of AS. So that's the significance of this ejection click if you have it. But it's not seen in all the patients with AS. What's the classic murmur? You're going to hear a classic ejection systolic murmur, ESM. Typically will be heard in the right upper sternal border. That's also called as the first or the original aortic area. And it will be a harsh murmur and a high-pitched murmur. And because it's a high-pitched murmur, I'm going to hear the murmur best, with the diaphragm of the stethoscope, not with the steth, rather with the diaphragm of the stethoscope. And you know, it's a left-sided murmur. It's a left-sided problem. So definitely the murmur will increase with expiration, and it's a aortic murmur. So when the murmur will be heard in left lateral portion or leaning forward portion, it's an aortic murmur, not a mitral murmur. Mitral murmurs are best heard in the left lateral position, but aortic murmurs are best heard in leaning forward position. If the patient is leaning forward, it will be best heard. All the aortic murmurs are best heard in leaning forward position because the aortic valve is going to come closer to the chest wall if the patient is leaning forward. So this is the typical ESM, and they will ask about the radiation of the murmur. Can anyone say where the murmur radiates? The classic ESM of AS, where it will radiate? Anyone? It is going to radiate to both the carotids, not axilla. Remember, axillary radiation is characteristic of MR. I forgot to tell there. Remember, radiation to axilla is characteristic of MR murmur because of the orientation of the jet like that. But aortic stenosis murmur is going to radiate characteristically to both the carotids. Radiation to bilateral carotids is classic of a AS murmur. Very, very important point. Not axilla, not back, to both the carotids. And sometimes in severe cases, the carotids literally dance. That's called as carotid shudder. Because of like turbulence of blood flow in the carotids literally shiver. And that's called as carotid shudder. So that also indicates a severe AS. Okay, now let us have a look at this hemodynamic data. Normally, during systole, the aorta and LV are in continuity with each other. If the aortic valve opens properly, the valve should be, the blood should be in continuity with both LV and aorta. But if the valve is stenosed, you're going to create a pressure gradient between LV and aorta during systole. I repeat, during systole, normally, if the aortic valve opens properly, the LV and aorta should have same pressure almost, because the valve is opening and the LV pressure is directly transmitted to the aortic pressure. But if there is an aortic stenosis, you're going to form a pressure gradient. Same thing, what we have discussed there. You're going to have higher LV pressures with lower aortic pressures, This is going to create that classic pressure gradient between LV and aorta. And because of this pressure gradient only, you're going to have that turbulence in the blood flow, producing that characteristic ejection systolic murmur during systole between S1 and S2. And ejection systolic murmur is otherwise called as mid-systolic murmur, but we don't use the term mid-systolic murmur. Rather, it is called as ejection systolic murmur only. And the typical ESM of aortic stenosis will be a diamond-shaped murmur, which is also called as a crescendo-decrescendo murmur, because it's going to increase initially and slowly the intensity will come down. That's called as a crescendo-decrescendo murmur. And most cases of AS murmur will be peaking in the middle of the systole. It will be a mid-peaking murmur. It will be peaking in the middle of the systole. In the middle of the systole only, the gradient will be maximum because the LV contraction force will be maximum. So it will be a mid-peaking murmur in most cases. But if they ask about a late peaking murmur, what do you have to answer? So if the murmur is peaking late like this, if the LV contraction is peaking at the end of the systole, this is indicative of high severity or low severity. If the LV contraction is peaking only in the late systole, it's contracting for a long period of time, it indicates high severity or low severity. It indicates very high severity. Very high severity. So whenever they talk about late peaking murmurs like this, it almost always indicates high severity. And these type of murmurs are also called as kite-shaped murmurs. Kite-shaped murmurs. If it's a classic mid-systolic peaking, it is called as diamond-shaped murmur. But if it's a kite-shaped murmur like that, it indicates high severity. Because LV has to struggle harder to produce a peak. So, I mean, somebody is asking why? My God. So LV see, if the valve is like not stenosed that much, it has to reach a peak very fast. Obviously, if the stenosis is so bad, then what's going to happen? It's going to take a long time. It's going to struggle like anything to reach a peak. Okay, let me assume you're climbing a hill and you're climbing without anything. So you're reaching the peak at some point. You're climbing somehow. But if I'm adding a weight to you, like maybe I'm adding like 20 kilogram of bag on top of you, will you be able to reach the peak faster, or are you going to reach the peak slower? Tell me, faster or slower? If I'm going to increase the load on you, you're going to reach slow. Obviously, you're going to get a slow peaking murmur only. It will be a late peaking murmur only. So that's all. If you're going to have a late peak, kite-shaped murmur, high severity. Okay. So what are the things I'm going to look for? Very simple. I told you. Simple. Whenever there is an obstruction. So let me show like this. Whenever there is an obstruction, first, across that obstruction, you're going to have high velocity or low velocity. Tell me faster, because you have to finish. Across that, you're going to have high velocity, right? So more the obstruction, more the velocity. And what about the pressure? The distal pressures will drop. The proximal pressures will increase. And this is going to create a gradient. Normally, there shouldn't be no gradient, but this is going to create a gradient. Whenever you put an inverted triangle like this, it indicates gradient. So that gradient also can be measured. So what is the pressure difference across the obstruction? If the gradient is more, means the obstruction is very severe. That's what it indicates. Number 3, I can even find out the aortic valve area. If it's very low, it indicates high severity. That's what exactly I'm going to look at. You're going to use something called as rule of force. So what do you mean by rule of force? In echocardiogram, we're going to look at the jet velocity. If it's more than 4 meters per second, high velocity indicates high severity. If the mean gradient across the LVOT is higher, more than 40 millimeters of mercury, indicates high severity. This is what we call as rule of 4. Jet velocity more than 4 meters per second and mean gradient more than 40 millimeters of mercury. Of course, if the aortic valve area is lower, like less than 1 centimeter square, indicates high severity. What do you mean by indexed aortic valve area? Nothing. Aortic valve area will be divided by body surface area. That's called as indexed aortic valve area. So if it is less than 0.6 centimeter square per meter square body surface area, that indicates high severity. So what do you mean by mild aortic stenosis? If the jet velocity is less than 3 meters per second, or the mean gradient is less than 20 millimeters of mercury, or if the aortic valve area is more than 1.5 centimeters square, or if the indexed aortic valve area is more than 0.85 centimeters square per meter square, that indicates mild disease only. But this is what is going to be more important. At least the first 3 points you need to definitely remember in exam. If the jet velocity more than 4 meters per second, if the gradient is more than 40, that's called rule of 4, or if the aortic valve area is less than 1 centimeter square, it indicates high severity. Are you able to understand the concepts behind how I'm going to assess the severity in echocardiogram in patients with aortic stenosis? So why velocity is important, why the gradient is important, why the aortic valve area is important. Yes, right? That's it. It's done. Okay. So again, indications for surgery for aortic stenosis is very, very simple, straightforward. What is the indication for surgery? So first, any symptomatic valvular heart disease, we know that. So symptomatic severe AS, you yourself can answer now, symptomatic severe AS. Number 2, you can perform surgery even in an asymptomatic patient with severe AS, provided you're having some complications. So what complications you can expect here? Over time, what happens really? If the LV keeps struggling to push blood against your aortic valve, so what happens? What complication you're going to explain? What complication you're going to expect? LVH is not a complication, basically. Not really. Okay, that comes under symptoms. Okay, Ali Usman is telling syncope, but it comes under symptoms, right? So what happens? Yes, Vignesh is correct. LV failure. I cannot keep on pushing the blood against a kind of obstruction for on and on and on forever. I will ultimately fail at some point. I'll get like fatigued, frustrated, and I'll fail. No, not cyanosis. We're talking about, see, think in terms of like echocardiogram. We're talking about EF. If it's less than 50%, yes, that's a sign of failure. That's a sign of failure. So EF less than 50%. So that's extremely important. That indicates that you have to operate because LV is failing. Or alternatively, here you have one more rule, one more additional rule. Suppose tell me I'm having severe aortic stenosis. I'm undergoing a bypass surgery. I'm undergoing bypass surgery because I'm having coronary artery disease. Because most of these patients with AS are older. And it's because of calcification. And there is a lot of chance that they can have severe coronary artery disease. So let me assume I'm undergoing a bypass surgery because of coronary artery disease. I'm going to cut open the sternum and I'm going to open the chest. I'm going to do bypass surgery. And I'm also having a severe AS. So will you like leave it? Okay, fine. We can open the heart one more time later on. Or you're going to do the aortic valve replacement at the same time. It's better. Yes, it's better to do at the same time, right? So why you want to wait for long? Anyway, you're going to cut open the heart. Patient is also having a severe AS. So if they are undergoing any other cardiac surgery, like bypass, undergoing any other cardiac surgery. Are you understanding the rationale behind this? Yes or no? Are you understanding or not? Yes or no? That's all. These are the indications for surgery, class 1 indications for doing an aortic valve replacement. So symptomatic severe AS, our same rule and our same old rule, asymptomatic severe AS with some complication. Here it is heart failure, EF less than 50%. Plus if they are undergoing some other cardiac surgery, I can do the aortic valve replacement at the same time. So the surgery of choice, treatment of choice is going to be aortic valve replacement. That's it. That's the surgery of choice. That's the treatment of choice. Aortic valve replacement. But this is an open procedure. I have to cut open and I have to do aortic valve replacement. If the patient is unfit, if I'm not able to do aortic valve replacement, what is the procedure I'm going to do here? That's called as TAVI. That's called as transcatheter aortic valve implantation. This can be done in patients who are not fit for surgery. I told you percutaneous balloon mitral valvotomy, right? Likewise, you can do a percutaneous procedure without cut opening the chest. That's an intervention. That's called as TAVI, transcatheter aortic valve implantation. So through the catheter itself, I can go to the aortic valve area and I can implant a new aortic valve in that area and come back. So that's called as transcatheter aortic valve implantation. This will be usually done for surgically unfit patients with severe aortic stenosis. Okay, there is another interesting concept over here. Let me tell you. That's called as low flow aortic stenosis. Can we do balloon valvotomy here? No. It doesn't work really because that will result in severe aortic regurgitation because the aortic pressures are actually quite high. So that's the reason it will result in AR usually, and balloon valvotomy is not a very good option. So you have to replace the aortic valve with a new aortic valve, but that can be done with the help of a transcatheter procedure. That's called transcatheter aortic valve implantation. That's what is done. We don't do balloon valvotomy. Okay, now there is a concept called as low flow aortic stenosis. So how you are going to find out aortic valve? Suppose how I'm going to find out the aortic valve area. This is the aortic valve opening area. That's what I'm going to find out. So how much the valve is opening? That's what I want. That's what I'm going to find out in echocardiogram. So there are two options. Whenever there is reduced aortic valve area, I have two possibilities. One, the patient can have reduced aortic area because of a true stenosis. That is because of a true aortic stenosis itself, or the aortic valve opening can be reduced if the patient is having heart failure. Tell me, if the patient is having heart failure, if the LV is failing, okay, if the LV is failing, do you think the force of contraction is going to be more? Yes or no? The force of contraction of LV will be more or less if the LV is failing. If the LV has failed very badly, the force of contraction will be less. If the force of contraction of LV is less, what's going to happen to the opening of aortic valve? It's going to open very nicely, it's going to open very less. If the force of contraction of LV is small, yes, it's going to open very less. So because it opens very less in a patient with heart failure, you can notice the low aortic valve area. The aortic valve opening area will be very less. That is called as pseudostenosis. That's called as pseudostenosis. First of all, just tell me, are you understanding the difference between true and pseudostenosis? True AS is different. Pseudostenosis occurs in patients with heart failure. Are you understanding or not? because aortic valve doesn't open properly in a patient with severe heart failure. Okay, all right. So the question is, so now this concept is over. The question is, if a patient is coming with reduced aortic valve area, and if the patient is having very low ejection fraction, very low EF, very low, like 20%, 30%, very low ejection fraction. And if the patient is having not increased mean gradients and pressures, let us assume the velocities are not in the severe AS range. Velocities are less than 4 meters per second, and velocity and the gradient, the pressure gradient is less than 40 millimeters of mercury. The mean gradient is less than 40 millimeters of mercury. But the aortic valve area is less than 1 centimeter square. So which means the aortic valve area is very low, less than 1 centimeter square, indicating that the opening is like affected very badly. But the velocity and gradient are actually quite low. In the sense, it's not fitting under severe AS. There is a mismatch. Look at here. So in a patient with severe aortic stenosis, if the valve area is less than 1, they should have a higher jet velocity and a higher gradient. But this patient is having a like not so higher velocity and not so higher mean gradient. So this is what we called as low flow, low gradient situation. Here, the problem can be two things. Either the patient is having severe aortic stenosis and that has caused a severe heart failure. And because of severe heart failure, the ventricle is not contracting with enough like strength to produce a good gradient and a good velocity. That is one possibility. Second possibility is the patient is having heart failure as the primary problem. And because the patient is having primary heart failure and aortic stenosis is not the problem here, because the patient is having heart failure, the AVA is less. And because there is no aortic stenosis, the velocity and gradient is not that high. So there are two situations here. How will you sort out the confusion? So we have to do something called as dobutamine stress echocardiogram. We have to do something called dobutamine echocardiogram. So dobutamine is an inotropic agent. It's going to increase the force of contraction. So after giving dobutamine, if the aortic valve area remains the same, aortic valve area doesn't change at all. It is still less than 1 centimeter square only. And if the velocity, jet velocity increases, if it becomes more than 4 meters per second, and if the gradient becomes more than 40 millimeters of mercury, so you think this is a true stenosis or a pseudo stenosis due to heart failure? Remember, once the heart starts contracting normally, no. Before telling the answer, think carefully. Once the heart's contracting normally, the gradient and velocity starts increasing, but the aortic valve area doesn't improve. Aortic valve area doesn't increase at all. Aortic valve area still remains the same. But velocity and gradient starts improving once the heart starts contracting normally with a higher strength. It indicates a true aortic stenosis. That's it. It's a true AS. On the other hand, after giving dobutamine, let us assume the aortic valve area increases. There is increase in the aortic valve area. But velocity and the gradient remains the same. There is no change in the velocity and the gradient. But aortic valve area improves, which means after the heart starts getting good contraction, the aortic valve opens normally. Which means here the primary problem is heart failure or a true aortic stenosis. What is the primary problem here? After giving dobutamine, once the heart starts contracting normally, your aortic valve opening increases, but velocity and gradient remains the same. Of course, it means it's pseudostenosis due to heart failure. It is pseudostenosis due to heart failure. It is not a true stenosis. Because the patient's primary problem is heart failure here, because the force of contraction of the heart was less, the aortic valve area was less, the opening was not good, and because the patient did not have stenosis in the first place, the gradient and the velocity was less. It's not in the severe AS range. But once the heart starts contracting normally, the aortic valve starts opening better, but the velocity and gradient still remains the same because there is no stenosis at all here. There's no problem in the aortic valve. That's what we call as pseudostenosis. So this is where you have to do dobutamine echo. So that's a very important concept. There is something called as low flow aortic stenosis, low flow, low gradient aortic stenosis. So to separate them, we have to use dobutamine stress echo. Let me show you a clinical vignette. Look at this patient, a 15-year-old male presents for further evaluation for recurrent congestive heart failure. Vitals are okay. Examination revealed edema and bibasilar crackles, which means patient is having evidence of heart failure. Aortic impulse displaced and sustained. Remember, aortic impulse, apical impulse is displaced and it is sustained. And patient is having a summation gallop, which means patient is having first, second, and third heart sound. Echo reveals a dilated left ventricle with an EF of 25%, which means EF is very, very low, 25%. Aortic valve is calcified with restricted leaflet excursion. The peak and mean gradients are 25 across 15 millimeters of mercury. Aortic valve area is less than 1 centimeter square. That's only 0.7. What is the next step? Can you tell me? This is one of the AIMS questions. Very old AIMS question, but still a very important question. So what is the right answer? So you're having a situation where the patient is having very low aortic valve area, less than 1 centimeter square, but the velocity, jet velocity is less than, velocity they have not given, okay, but they have given the gradient. The gradient is less than 40 millimeters of mercury. They have mentioned that the mean gradient here is just 15 millimeters of mercury. The mean gradient is just 15. It's less than 40 millimeters of mercury for sure. And the patient is having a low ejection fraction. It's only 25% in this case. So what is the next step? Can anyone say? First, you need to separate, right? You need to know whether this decline in the aortic valve area is a kind of a true stenosis or a false stenosis due to heart failure. How will you separate true stenosis from pseudostenosis? Right answer is C, dobutamine echo. That's what we're going to do. Yeah, you have to separate true stenosis from pseudostenosis here. I have to give dobutamine. As I said, in case if it's going to be a pseudostenosis, after giving dobutamine, the aortic valve area will definitely improve. It will become more than 1 centimeter square because the opening will become good, but the gradient will still remain the same. It will not change that much because there is no stenosis in the first place. So that is the reason why the answer for this question is dobutamine echocardiogram. Are you understanding or not? Yes or no? Are you understanding or not? Why the answer is C for this? Okay. All right. So you have completed aortic stenosis also. The only final valvular heart disease that is left is aortic regurgitation. So what is the etiology of aortic regurgitation? There are two important etiologies. One is valve disease and second is root disease. The problem can be in the valve or problem can be in the root. So which is more common? Can you tell me? The problem in the valve or problem in the root? Which is going to be more common in the modern era? Valve problem or root problem? Correct. So root problems are more common. Approximately 60% of case of AR will be due to root problem and only 40% of the case of AR will be due to valve problem. So root problem in the sense because of root dilatation, the valve becomes like farther apart so that it will not be able to close properly. It will be leaky. So that's why you're going to result in aortic regurgitation. So root problem. So what are the conditions that are associated with root problems? Anything that dilates the aortic root. What's going to dilate the aortic root? Whenever there is more afterload, whenever there is more pressure in the aorta, the root is going to get dilated. Marfan's is fine, but one of the most important causes of aortic root dilatation, hypertension. Because in hypertension, you're going to have more afterload, excessive pressure in the systemic vasculature. You're going to have dilation of the aortic root. That's very, very common. And apart from that, aortic aneurysm, aortic dissection. Whenever write AOA, it's aortic aneurysm. Whenever write AOD, it's aortic dissection. Apart from that, patients can have Marfan syndrome. That can be the reason for root dilatation. Or it can be due to aortic root inflammation. Inflammation of aorta. Can you say what are the conditions that cause aortic root inflammation? Any large vessel vasculitis like Takayasu arteritis can cause aortitis, right? For that matters, ankylosing spondylitis. Ankylosing spondylitis can cause aortitis. In fact, the most common valvular heart disease in the setting of ankylosing spondylitis is AR. I don't know how many of you know that. I told you in so many of my classes before, the most common valvular heart disease in the setting of ankylosing spondylitis is aortic regurgitation. Or it can be due to syphilis causing inflammation of the aortic root. Or it can be due to conditions like reactive arthritis, which is also called as Ritter syndrome. So these are some examples of aortic inflammation, aortitis, causing damage to the aortic root, causing aortic regurgitation. And what about the valve disease? I told you 40% patients are going to have valve disease, right? When it comes to valve disease, the usual reasons will be conditions like rheumatic heart disease, which is not very common nowadays. Or it can be due to bicuspid aortic valve. I told you bicuspid aortic valve is a condition that can result in AS, AR, or both AS and AR. Or it can be due to infective endocarditis, a very, very important cause. Infective endocarditis. Apart from that, rarely connective tissue disorders, CTDs like SLE, rheumatoid arthritis, certain drugs, and even radiation therapy can damage the aortic valve. But these are not very common. These are rare. The usual valve causes will be either rheumatic heart disease in India or a bicuspid aortic valve, or it's going to be infective endocarditis. In this, tell me the causes of acute AR. Who's going to tell me the cause of acute AR? Only two conditions are there which can cause acute AR. Very important for exams. What can cause acute aortic regurgitation? Sudden onset AR. One is there right in front of you. It is infective endocarditis. Second is aortic dissection. Two important causes. That's it. These two conditions are going to cause acute aortic regurgitation. Infective endocarditis, aortic dissection. I repeat, infective endocarditis and aortic dissection. Both can produce acute aortic regurgitation. So what will be the hemodynamics? Very simple and straightforward. Technically, I told you in aortic stenosis, the main problem is increased LV pressures. Here, because of regurgitation, you're going to have increased LV volumes. In one word, if you want to say the hemodynamics, it's increased LV volume. That's it. That's the most important thing. And in MR, the ventricle did have two outlets. A part of blood goes into left atrium. But here, whatever blood that comes back into LV, everything is going to go into aorta only. Let us look at that classic example. Okay, so let us assume this is the aorta, and here's the LVOT, and let us assume this is the mitral valve. And you're going to have the left atrium over there. And what happens is, during diastole, the mitral valve will be open, all right? Let us assume during diastole, the mitral valve is open. The blood is flowing from mitral valve, left atrium to left ventricle. But the problem is, during diastole, the aortic valve should be closed. Aortic valve should not be open. But in aortic regurgitation, the aortic valve is going to leak. It's going to leak blood back into the LV. So now the LV is getting filled by two sources. One, by the left atrium. Another source is actually the aorta itself. Because the LV is getting filled by two sources, by LA as well as aorta, you're going to have more volume in LV or less volume in LV? What will be the volume in LV? You would have more volume or less volume? You're going to have more volume. So patients are going to have LV volume overload. You're going to have LV volume overload. So because of LV volume overload, you know what are the things that are going to happen. So number one, what will be the apical impulse? It will be displaced or non-displaced. What will be the apical impulse? Because of LV volume overload and LV dilatation, the apical impulse will be displaced, typically down and out. And this excessive volume in the left ventricle is going to result in more contraction or less contraction by Frank-Starling law. You're having more end diastolic volume, more volume, so more contraction. So once again, you're going to have hyperdynamic left ventricle. The apical impulse will be hyperdynamic in nature, very fast, forceful contraction, but not sustained for a long time like heaving, because there's no obstruction over here. So it's going to be like a quick and a forcible contraction, hyperdynamic, brisk contraction. And number two, because of the LV volume overload, do you think third heart sound is common or fourth heart sound is common? Which is more common, third or fourth? Of course, third heart sound. So patients are going to have third heart sound. Fourth heart sound can occur, but in acute AR, that's it. But otherwise, you're going to have third heart sound very, very commonly, LVS3, because of LV volume overload. Okay, all right. So, and because the force of contraction is higher, remember, during systole, what happens? If you draw the ventricle during systole, there will be good closure of mitral valve, and the aortic valve is going to open like this. Because the force of contraction is going to be too much, it's a very powerful contraction. because of more volume during the diastole, there'll be a lot of blood that will be ejected into the aorta. So because a lot of blood is moving into the aorta, you think the volume of the pulse will be more or less. Here, the blood is only moving into aorta. It's not going anywhere else. In MR, at least a part of blood is going into left atrium. But here, all the blood, whatever has come into the left ventricle during diastole, everything is moving into the aorta. So that's the reason why here the pulse volume is also going to be quite high. Sandy, if you see the actual cardiac output will be more or less here. These patients are having more cardiac output or less cardiac output? Yeah, they are having actually more cardiac output. Do you think the peripheral vessels to get adapted to this more cardiac output, they should dilate or they should contract? They should constrict. If you want to push more blood into the vasculature, to adapt, they should dilate or they should constrict. They should dilate to adapt that excessive blood over a period of time. And dilatation of the peripheral vasculature will reduce the systemic vascular resistance or increase the systemic vascular resistance. It's going to reduce the systemic vascular resistance, right? You're going to have reduced systemic vascular resistance. So increased cardiac output will increase the systolic blood pressure or decrease the systolic blood pressure? Leading question again. Increased cardiac output is going to increase systolic blood pressure or decrease systolic blood pressure? You're going to have increased systolic blood pressure. And reduce the systemic vascular resistance is going to increase diastolic pressure, reduce diastolic pressure. Reduce systemic vascular resistance is going to increase or decrease diastolic blood pressure. This reduced systemic vascular resistance is going to reduce the diastolic blood pressure. DBP will reduce. If the SBP increases and DBP reduces, what happens to the pulse pressure? What happens to the pulse pressure? Pulse pressure will become wide. Pulse pressure will increase. That's why you're going to have a bounding and a pounding pulse in patients with aortic regurgitation, right? So what will be the features of aortic regurgitation? Clinical features, patients are going to present with palpitations. Very commonly, they're going to have palpitations because of pounding of the left ventricle. Left ventricle contracts like harder and harder and harder. So that itself is going to cause a kind of a thumping and the thudding sensation in the chest. And that's how we call that. That's how the patient develops palpitations. And of course, once the LV starts failing, that's the time where the patient develops the shortness of breath, heart failure symptoms, and so on. But before that, one of the important things that the patient develops is angina. Can you say why the patient develops angina? So for that, you need to answer the coronaries fill during systole or diastole. The coronaries are going to fill during systole or diastole. Predominantly, coronary blood flow is going to occur during systole or diastole. Okay, during diastole. But during diastole, the blood stays in the aorta or blood comes back to the LV here. The blood comes back to the LV. If the blood doesn't stay in the LV and if it comes back to the LV, what will be the coronary blood flow? It will be poor or it will be more? It will be poor. Okay, so that's one of the main reasons why these patients can develop angina as well. Because or we can say in another way. So look at the diastolic blood pressure. Diastolic blood pressure is low in these patients. If the diastolic blood pressure is very low in these patients, during diastole, the coronary blood flow is going to be very poor. They don't have sufficient pressure to perfuse the coronaries. So that's the reason why they develop angina. Hope you understand this. So palpitations are common. Angina is also very common. Interestingly, most of the patients develop angina in the night. Tell me why they develop angina in the night. During night, your heart rate will decrease or increase when you're sleeping. What will happen to the heart rate? Heart rate will decrease. If your heart rate decreases, what will happen to your diastolic time? What will happen to diastolic time? Diastolic time will increase or diastolic time will shorten. If the heart rate decreases, what will happen to diastolic time? My God, diastolic time is going to increase. Of course, simple. See, as the heart rate decreases, the cardiac cycle length will keep increasing, right? As the heart rate increases, cardiac cycle length will decrease. So as the heart rate decreases, your cardiac cycle length is going to increase. It's going to be more. So the diastolic time is going to be more. In AR, the event is happening during diastole or systole. In AR, the event is happening during diastole or systole. During diastole, if the patients are going to have increased diastolic time, the regurgitation is going to get worse during nights. That is because of the decreased heart rate. That's the reason why most of the patients are going to develop angina during the nights. Yes, it's typically going to get worse during the nights. That's because of reduced heart rate in the night, increasing the cardiac cycle length, which in turn is going to increase the diastolic time, which is going to worsen the regurgitation. Worsening regurgitation is going to be associated with worsening coronary perfusion. That's going to worsen the angina. That's why most patients typically tend to experience anginal episodes in the night. And once the patient develops heart failure, so once the patient starts developing heart failure, that is the time they start developing shortness of breath, exertional dyspnea, and patients can develop pulmonary edema, pulmonary congestion, and so on. That occurs a little later, not immediately. In the early stage, all the patients are going to have is palpitations and probably angina, especially in the night, nothing more. So what will be the pulse in patients with aortic regurgitation? The pulse is going to be like hyperkinetic. Along with that, you're going to have large volume pulse. The pulse is going to be of large volume, not small volume, a very important point. Large volume pulse, and it will be like with a very high pulse pressure, or you can call it as a wide pulse pressure, and you can call it as a bounding pulse. And more importantly, if they ask you the pulse character, you're going to have a kind of a collapsing pulse, or otherwise called as Watson's water hammer pulse. Collapsing pulse, or otherwise called as Watson's water hammer pulse. What do you mean by a collapsing pulse? It's going to be a rapid rise followed by a rapid fall. Rapid rise followed by a rapid fall. That's what we call it as collapsing pulse. Why it should rise rapidly? That is because of brisk ventricular contraction. Because of brisk LV contraction and a powerful LV contraction, you're going to have a rapid rise. And if they ask you why there's going to be a rapid fall, it is because of a concept of something called as runoff. Concept of something called as runoff. Runoff means it can be peripheral runoff or it can be a central runoff. Let me tell you what do you mean by peripheral runoff. First of all, let me tell you central runoff. Central runoff is typically due to blood. Runoff means blood is not staying in the central vasculature, which means blood is not staying in the major vessels like aorta and probably brachial artery, radial artery, or whatever. So blood is not staying in the major arterial compartment. It is running off somewhere. That's what we call it as runoff. Central runoff means it's coming back to some cardiac chambers. So in AR, the blood is coming back to the LV from aorta during this diastole. So that's why the blood doesn't stay in the central vasculature, and that's why you have a central runoff. Because of that, the pulse collapses rapidly. And number two, because of low systemic vascular resistance, the blood easily moves towards the peripheral vasculature, and again the blood doesn't stay in the aorta and other major arterial compartment, and that's the reason for the peripheral runoff. So central runoff, it's because of AR itself, and the peripheral runoff is basically because of low systemic vascular resistance, where the blood easily moves into the peripheral vasculature without staying for a longer time in the central vasculature. So this is the reason for the classic collapsing pulse in patients with aortic regurgitation, also called as Watson's water hammer pulse. Do you understand? Yes or no? So what do you mean by collapsing pulse, and what do you mean by runoff, and what do you mean by central runoff, and what do you mean by peripheral runoff? Okay, all right. And some patients with severe AR, can also develop Bispherians pulse. Bispherians pulse, which is a double peaking pulse, not important right now. They can also develop a Bispherians pulse. So what about jugular venous pressure? Left-sided event, so typically normal. For AR to cause abnormal JVP, patient should have a seriously bad heart failure. Otherwise, patients are not going to develop elevated JVP. Only in CCF you can have elevated JVP. Otherwise, JVP will be normal in most patients with AR without any much of heart failure. What about apical impulse? We discussed already. The character of apical impulse will be hyperdynamic, a thumping but a short-lasting apical impulse, and it will be like displaced. It will be displaced down and out. Very, very important. Yeah, displaced down and out. Correct. And what about the heart sounds? S1 will not be affected in aortic disorder. So S1 will be usually normal. There won't be much problem in the S1, but S2, especially the A2 component, can be soft or it can be normal. So if they ask you where A2 will be soft, in patients with valve disease. If it's a valvular aortic regurgitation, it will be soft only. But if it's a root-related problem, it can be normal. If it's a root-related problem like Marfan syndrome or probably Takay's arthritis or syphilis causing AR, the second heart sound, the A2 component can be normal. Only in valve disease, it will be soft. But overall in exam, if you want to know one answer, you can go for soft. But it depends on whether it's a valve problem or a root problem. What about extra sounds? The most common extra sound that we see is LV S3, the third heart sound. That's the most common extra heart sound. But if at all I ask you, I gave you the concept already. In case if you see S4, what does that indicate? In case if I hear S4, fourth heart sound, what does that indicate? It's a stiff LV, which means the LV is not yet completed. It's not dilating properly. Which means what does it mean? What's the inference of that? It indicates it's an acute AR. That's all. Because in acute AR, the LV will be very stiff. The blood that's coming back from aorta into the left ventricle will not be able to stretch LV. Rather, it will cause the fourth heart sound. Okay, right? So in acute AR, you can have fourth heart sound. So that's a very important point. And what's the classic murmur that you're going to hear in the setting of aortic regurgitation, a chronic AR? So it's going to be early diastolic murmur. Early diastolic murmur, that's what you're going to see. EDM, where it is best heard. It's best heard in the Hub's point. Hub's point is also called as neo-aortic area or otherwise called as second aortic area. It's not LLSB. It's not left upper sternal border. It's somewhere in between your left lower sternal border and the left upper sternal border. It's somewhere in between. In old textbooks, they will mention as left third intercostal space close to the sternum. So that's the Hub's point or Hub's area, but it's between the left lower sternal border and the left upper sternal border, somewhere in between. That's called as Hub's area or Hub's point. So how will you describe the early diastolic murmur? It's a kind of a harsh and a blowing murmur. It's a high-pitched murmur. Because it's a high-pitched murmur, obviously you're going to hear best with the diaphragm of the stethoscope and not with the bell of the stethoscope. And this early diastolic murmur is going to be augmented with expiration. Why? Because it's a left-sided event. Because it's a left-sided event, it's going to get augmented with expiration, and it will be better heard in the leaning forward portion. If the patient is leaning forward, it will be heard better heard. If the patient is in the leaning forward portion. Obviously, because it's an aortic murmur, an aortic wall comes closer to the chest wall in leaning forward portion. And more importantly, in case if it's a chronic AR, you will notice something called as peripheral signs of AR. There are lots of peripheral signs. It's not at all important for NEET or NEXT or whatever exams you're attending. So maybe in theory, clinical exams for a final year, they can ask about the peripheral signs, but for a competitive exam, it's not important. Peripheral sign in the sense you have a lot of signs. You have Lighthouse sign, you have Landolfi sign, you have Quincke's sign, you have De Merset sign, you have Denison sign, you have Rosenbach sign, you have Muller's sign, you have Gerhard sign, you have Watson's Waterhammer pulse, you have Corrigan sign, you have De Merset sign, you have the pistol shot femorals. Okay, that's also called as Straub sign. Then you have pistol shot radial arteries, that's also called as Palfrey sign. So you have so many peripheral signs. It's not that important for a competitive exam, but you have to know about that. In exam, if they say, if an examiner is sitting in front of you and asking, if you want to say that this is acute AR, how will you substantiate? Because EDM can be seen in acute AR also. So if you want to say it's acute AR, so what are the 3 points? You can just straight away hit on the head, 2 points, not even 3 points, just 2 points. First is S4, correct. Second, when we say it's acute AR, say absence of peripheral signs. You're not going to have any peripheral signs in acute AR. Peripheral signs will take some time to develop. So 2 classic findings. If at all, if examiner is standing in front of you asking so what are the important signs of acute AR? Just say S4. Number 2, no peripheral signs. Only in chronic AR are going to have peripheral signs. In acute AR, you don't have peripheral signs, no matter what. And if you want to say, third point, you can say the EDM is going to be very, very short. The early diastolic murmur is going to be very short in an acute AR because LV is not complete. It will not be able to receive blood for a long time. So the EDM will be extremely short. And there is an entity called Austin-Flint murmur. So what is Austin-Flint murmur? So let me draw another image again. So what happens during diastole? So during diastole, you know, the mitral valve should open. Mitral valve should open. And aortic valve should be closed. That's what should happen in diastole normally. But here the aortic valve is leaky and is leaking blood from the aorta back into the left ventricle. And if the patient is having severe aortic regurgitation, or if the patient is having stiff left ventricle, what happens is this jet will bounce off and it's going to impinge on the anteromitral leaflet. This jet is going to bounce off and it's going to impinge on the anterior mitral leaflet. So if it impinges on the anteromitral leaflet, it's going to prevent the opening of the anteromitral leaflet. So this AR jet is going to impinge on the AML, anteromitral leaflet. This is the anteromitral leaflet. This is the posterior mitral leaflet. So it's going to cause poor opening of the anteromitral leaflet. So this is going to reduce the opening area of mitral valve, or it's going to increase the opening area of mitral valve. So it's going to reduce the opening area or increase the opening area, overall area of the mitral valve. You're going to answer. Reduce or increase if the AML doesn't open properly. Anybody there? Yeah, you're answering. So it's going to, of course, decrease the opening area of mitral valve. So it results in something called as a functional MS-like situation. It's not a true mitral stenosis. Rather, this jet is causing poor opening of AML, causing a kind of a functional MS. And that is going to cause turbulence in the blood flow that is coming from LA to LV. And you're going to hear a mid-diastolic murmur. And this is what we call it as Austin-Flint murmur, AFM. So where you're going to hear Austin-Flint murmur? In two areas. One, in severe chronic aortic regurgitation. Or number two, in acute aortic regurgitation. Are you understanding? So Austin-Flint murmur will be heard in cases of either a very severe chronic AR or maybe in an acute AR where LV is very stiff. So that's where you hear Austin-Flint murmur. So if you want to say 3 points with regards to acute AR, one, you already said S4. Number two, again, we already discussed, that is no peripheral signs. Number three, you're going to say the EDM is going to be short, and most commonly you're going to see Austin-Flint murmur as well. That's it. It's done. Now let us look at the hemodynamic diagram. So this can be asked in exams. Okay. Normally during diastole, because the event occurs in diastole, here is the systole, there's no problem, but the problem is in the diastole. Here, the problem is in the diastole. So normally the gradient should be maintained, because if the aortic valve closes, properly, the aortic pressure is going to be like this. And then you will have something like this. The gradient will be maintained. So which means during diastole, the gradient between LV and aorta will be maintained. But because the aortic valve is leaking, the gradient is decreasing. You can notice that the gradient is actually coming down because the blood is moving from aorta back into the left ventricle. That's why you can notice that the LV diastolic pressure is increasing because of blood moving from aorta back into the LV, but the aortic pressures are dropping rapidly because of blood moving from aorta back into the left ventricle. So that movement of blood from LV, from aorta to LV during diastole is going to create a turbulence. And that is what we are hearing as early diastolic murmur after S2, that is diastole. So I repeat, because of blood moving from aorta back into the left ventricle during diastole, it's going to create a turbulence. That's what is heard as something called as early diastolic murmur in the setting of AR. But why we don't hear a kind of a murmur throughout the diastole? Is there anything called pan-diastolic murmur? No. We don't hear the murmur throughout diastole because once LV completely gets filled, you can't fill anymore. It is going to reach the maximum capacity. So after that, it cannot be filled anymore. So that's why you're going to have only the early diastolic murmur and not a kind of a pan-diastolic murmur here. And here the LV will get filled very fast because LV is getting filled by two sources. LA is also filling the LV, aorta is also filling the LV. So it's going to get filled very faster. That's why you're going to have only the classic early diastolic murmur and not a pan-diastolic murmur. So tell me one thing. Normally, the gradient should be maintained or gradient should be lost. Normally, during diastole, the gradient should be maintained or gradient should be lost. The gradient should be maintained. It should not be lost. If it is lost, and if it is lost very rapidly, tell me if it is lost, but if it's lost very rapidly, it indicates severe AR or a non-severe AR. It indicates a severe AR. So what is pressure half time? We discussed already, right? Pressure half time is the time period for the gradient to become half. That is what we called as pressure half time, the time taken for the gradient to become half. So here, if you look at the pressure half time, if the time taken for the gradient to become half, that is, the gradient is going to diminish rapidly, is going to be less, means it's more severe or less severe. It's more severe, correct. Yes, it's definitely more severe. So that is why in aortic regurgitation, we're going to see something called as pressure half time. How fast? Cannot understand about gradient. So I don't know what is there not to understand about gradient. So normally the pressure should be maintained. If the pressure is maintained, there should be a nice gradient. I told you the graph already, right? It should be something like this. So LV pressure should be something like this. So there should be normally a nice gradient should be maintained between aorta and left ventricle. But if the aortic pressure like drops dramatically because of blood leaking back into the left ventricle, the LV pressures are going to increase because of that. So the gradient is going to diminish rapidly between LV and aorta. And how fast the gradient decreases, it's going to tell you the severity. So you yourself said just a while ago that if the pressure half time is very, very short, which means it's going to take only a very short time, like less than 200 milliseconds for the gradient to become half, it indicates high severity. If it takes less than 200 milliseconds, which means the gradient is becoming half in a jiffy. So within 200 milliseconds, highly severe. On the other hand, if the pressure half time is more than 500 milliseconds, which means it's taking some time for the gradient to become half, which means it's slowly only leaking. It's not leaking very rapidly. So it indicates a mild AR. That's it. And of course, same thing, same parameters we're going to use. I told you for any regurgitation, we're going to look at the jet width and how much it fills the left ventricle or whatever the regurgitant chamber is. What is the vena contracta, the narrowest point, regurgitant fraction, regurgitant orifice. I mean, it is regurgitant volume, regurgitant fraction, regurgitant orifice areas. All these things we're going to look at. So what we're going to do is we're going to compare the jet width, how big the jet is, and we're going to compare that with left ventricular outflow tract. If you look at this image, where is that? The previous slide, I've shown you that the jet is going to come back into the left ventricle via the left ventricular outflow tract. If the jet is big, it's going to cover a huge area of left ventricular outflow tract, right? So if you compare the jet width with the left ventricular outflow tract, if the ratio is more, it's going to indicate high severity, right? So if the jet width by LVOT is more than 65%, more than 0.65, which means I'm saying that the jet of the aortic regurgitation is covering more than 65% of the left ventricular outflow tract. That is very severe. If the jet width by LVOT is less than 25%, which means the LVOT is occupied by only 25% by the jet of the aortic regurgitation, it indicates mild aortic regurgitation only. You know, vena contracta means the narrowest portion. The narrowest portion itself is wider, like more than 0.6 centimeter, indicates high severity. If it's less than 0.3 centimeter or less than 3 millimeter, so indicates mild AR only. Then regurgitant volume, you know that if it's more than 60 ml per beat, which means the regurgitation volume is absolutely more than 60 ml per beat, severe AR. If it's less than 30 ml per beat, it is mild AR. Regurgitant fraction, again, of course, if the amount of regurgitated blood is more than 50% of the blood that is going out of the aorta during systole, it is severe. If it is less than 30%, it is mild AR only. So regurgitant fraction means amount of blood that is coming back into the LV during diastole. So that is ejected during systole. So that is regurgitant fraction. And the regurgitant orifice area means, so the area of the regurgitant orifice, if it's more than 0.3 centimeter square, it's severe. If it's less than 0.1 centimeter square, it's going to be mild. So nevertheless, what you need to know is the severe AR features only. This is what we need to know. All these things we have discussed already in the MR section. The vena contracta, regurgitant volume, regurgitant fraction, regurgitant orifice area. Only the numbers will be slightly different. And extra, I've added the diastolic pressure of time. And apart from that, I've added the jet width by LVOT ratio. So if the jet width is more than 65% of the LVOT area, so that indicates a severe AR. So do you understand this? So what are the markers of severity? Remember, you can mug up the numbers later on, but have you understood the concepts? That's what is more important. So what we are trying to really achieve here, what you're trying to do here, what you're trying to find out. So that's what is more important. It's not about the numbers. Numbers you can mug up anytime, so that's fine. But the concept is important. So why it is done? That answer of why is what is going to tell you whether you're going to remember for a long time or not. Okay, all right. So now what are the indications for surgery? So again, you know that there are only like two indications, two classic indications we have been discussing for so long. First, symptomatic severe valvular heart disease. So if the patient is having symptomatic severe AR, indication number 1. Number 2, if the patient is asymptomatic, still I can perform surgery in a patient with severe AR, provided if I have some complications. What are the complications? Of course, AR patients are going to have heart failure, not right ventricular failure, left ventricular failure. If the EF is less than 50%, number 1. Number 2, if the LV is dilated to a huge amount, that indicates severe AR, because in AR, the amount of blood that is coming back into LV is going to determine the LV volume also. What that matters, if the LV end systolic diameter, if it's more than 55 mm, or if the LV end diastolic diameter, if it's more than 65 mm, this also can be considered as an indication for surgery. Or alternatively, like in other aortic surgeries, if the patient has been planned for other cardiac surgeries. Other cardiac surgery, like for example, a coronary artery bypass grafting, I can do aortic valve replacement at the same instance. So the treatment of choice here is aortic valve replacement. To be honest, TAVI is not a very good option for aortic regurgitation. So we have to perform a surgical aortic valve replacement only. That's the treatment of choice. So indications very simple. Our usual norms: symptomatic severe valvular heart disease or asymptomatic severe valvular heart disease, provided patient is having some complications like EF less than 50% or a huge left ventricle like LV and systolic diameter of more than 55 or end diastolic diameter of more than 65, or patient has been planned for any other cardiac surgery. Along with that, if the patient is having a severe AR, even if they don't have symptoms, I can plan for surgery. That is aortic valve replacement. Do you understand this? Aortic regurgitation as well? Yes or no? Yes, right? Okay, cool. So maybe if you revise one more time, you can understand things much, much better. That's all. Finally, I'm going to talk only about prosthetic valves. And what will be the anticoagulation that will be given to prosthetic valves has been a very common question. There are two types of prosthetic valves. One is bioprosthetic valves. Second is going to be mechanical valves. Bioprosthetic valves, and I'm having something called as mechanical valves. So what are bioprosthetic valves, by the way? How will you choose bioprosthetic valves? So these are like natural tissues. And usually we are going to choose bioprosthetic valve in patients who are old and patients who have contraindications to anticoagulation. Why? The durability of bioprosthetic valves is quite less. It's going to last only for 8 to 10 years, not more than that. So because you need only a short term, it's not like don't need anticoagulation, you need only a short term anticoagulation. So old patients and those who are having contraindications to anticoagulation, these are the best group of patients for bioprosthetic valves. And the problem with bioprosthetic valves is the fact that they are not very durable. So that's the reason why we choose older patients for bioprosthetic valves, whose life expectancy is not that great. Mechanical valves, on the other hand, the advantage is durable. Advantage is the fact it's durable. It can last for like 15 to 25 years easily if you maintain them well. It's very, very durable, high durability. And that's why we're going to choose for younger patients. But the one bigger problem with mechanical valves is it needs lifelong anticoagulation. So that's why two important parameters we have to think about. Patient should be younger, plus patient should not have any contraindication to anticoagulation. Then only I can choose mechanical valves. Okay. So what are the clinical features? Remember, your mechanical prosthetic valves or any prosthetic valve for that matters, especially mechanical prosthetic valve, is going to produce crisp sounds. And this sounds will occur during opening of the valve or closing of the valve. Crisp sounds, and they're going to produce a very soft murmur during opening or closing. During opening, that time they can produce a crisp murmur and crisp sounds and a soft murmur, which means only during forward flow. That is during opening. Only during forward flow. So this is normal. This is kind of normal. So they can have a kind of a very soft murmur and they're going to produce a crisp opening sound. So that should occur only during forward flow. And especially the murmur is very, very important. The murmur is very important and they will ask you an exam. So that soft murmur that you're going to hear should be heard only during forward flow. During forward flow only. Forward flow only. This is normal. Any murmur that you hear during backward flow is clearly abnormal. Any murmur that you're going to hear during backward flow is 100% abnormal. That indicates regurgitation and valve dysfunction. So which means if you have a mitral valve, mechanical prosthetic valve, which is normal, a diastolic murmur or systolic murmur, which is normal, if it's a mitral prosthetic valve. If it's a mitral prosthetic valve, diastolic murmur or systolic murmur, which is normal. No. So in mitral valve, the forward flow is happening during diastole or systole. Tell me, in mitral valve, the forward flow is happening during diastole or systole. The blood flows from LA to LV during diastole or systole. It's going to occur during diastole. So that's why a small diastolic murmur is okay in a mitral prosthetic valve. But you can never have a systolic murmur. If you have a systolic murmur in a mitral prosthetic valve, it indicates valve dysfunction. On the other hand, in aortic valve, if you're having an aortic mechanical valve, you should have the systolic murmur is normal or diastolic murmur is normal. Systolic murmur is normal. So that's a very important point to know. A soft diastolic murmur is normal if it's a mitral mechanical valve, and a soft systolic murmur is normal if it's a aortic mechanical valve. But if you have any systolic murmur in the mitral area, or if you're going to have diastolic murmur in the aortic area, it's clearly abnormal. That's not at all normal. So that indicates valve dysfunction and regurgitation of the valve. So what about anticoagulation? So what is the normal duration of anticoagulation for bioprosthetic valves? So we are going to use only warfarin when it comes to any prosthetic valve. And the target INR is going to be 2 to 3. And this should be maintained for at least 3 months. So minimum 3 months, that's the duration. And after that, you can just continue with aspirin alone for lifelong. Lifelong aspirin alone. So that's the current recommendation, which means you need only a short-term anticoagulation. Just for 3 months, you need warfarin. After that, you can just convert that to aspirin and you can continue that for lifelong. That's why I said you don't need lifelong anticoagulation for bioprosthetic valves. That's why in patients with contraindications to anticoagulation, you can probably use bioprosthetic valves. What about TAVI? Because this is a procedure that's been done at an increasingly higher rate in the recent past. So TAVI is transcatheter aortic valve implantation, where you don't even need any anticoagulation. All you need is just a dual antiplatelet therapy, DAPT for 3 to 6 months. All you need is just a dual antiplatelet therapy for 3 to 6 months. What do you mean by dual antiplatelet therapy? You're going to use 2 antiplatelet drugs. One is aspirin, second is a P2Y12 inhibitor, which is commonly a clopidogrel, but it can be prasugrel or ticagrelor or cangrelor. We don't use its IV drug, but nevertheless, most common drug that we use is clopidogrel, but it can be prasugrel or ticagrelor also. So DAPT for 3 to 6 months, and this will be followed by aspirin for lifelong, which means in TAVI also, you don't need that much of anticoagulation. Just DAPT. You don't even need warfarin here. Just a dual antiplatelet therapy for 3 to 6 months, followed by aspirin for lifelong. But when it comes to mechanical prosthetic valves, it's lifelong anticoagulation. There is no doubt about that. Lifelong warfarin So you have to be very clear. It's just lifelong warfarin. That's what you need to do. So what is the target INR? What is the target INR? If it's a mitral mechanical prosthetic valve, the target INR is 2.5 to 3.5. If it's a aortic mechanical prosthetic valve, the target INR is 2 to 3. So this is another very important point. If it's a mitral valve, the target INR is going to be 2.5 to 3.5. If it's aortic, it's going to be 2 to 3. Only in patients with high risk features, I can set an INR target of 2.5 to 3.5 in aortic valve. So what do you mean by high risk features? In case if the patient is having atrial fibrillation, or if the patient is having history of CVA, history of cerebrovascular accident, TIA stroke, or the patient is having very low EF of less than 30%, where the ventricle is not at all contracting properly. So the risk of stasis of blood in the LV and thrombus formation is very high. So in that condition, I can use INR target of 2.5 to 3.5, or if the patient is having a known hypercoagulable state like factor V Leiden mutation or APLA syndrome, or probably prothrombin mutation or protein C deficiency, proteinase deficiency, any hypercoagulable state, I can set INR of 2.5 to 3.5. Otherwise, if they bluntly ask in aortic portion, the INR is 2 to 3. In mitral portion, it is 2.5 to 3.5. That's it. And what about pregnancy? In pregnancy, trust me, the best drug is warfarin. There's no doubt about that. The best drug that can prevent thrombosis of the mechanical prosthetic valve is warfarin. There is no drug like warfarin, even in pregnancy. So it depends on what is the timing of pregnancy. I can make it as 5 to 12 weeks, 12 to 36 weeks, and beyond 36 weeks, and in the postpartum period. So what will be the choice? In 5 to 12 weeks, in the first trimester, how will you choose what kind of anticoagulation you require? It depends on warfarin dose. Look at the warf dose. If it's more than 5 milligram, if it's less than or equal to 5 milligram, you just continue with warfarin alone. You just continue with warfarin, no problem at all. And most studies have clearly demonstrated that if the patient's warfarin dose is 5 milligram or less, the teratogenic effect of warfarin is not that high. So you can safely continue warfarin if the warfarin dose is less than or equal to 5 milligram. But if the warfarin dose is more than 5 milligram, you have to switch over to low molecular heparin. Like for example, enoxaparin. This is a very, very important, a crucial point for exam. If the warfarin dose is less than or equal to 5 milligram, you can just continue with warfarin itself because the risk of teratogenicity at this dose is extremely low. You don't result in fetal warfarin syndrome. Only if it's more than 5 milligram, the risk is high, so that we're going to switch over to enoxaparin. In 12 to 36 weeks, it's a no-brainer. In second and third trimester, I'm going to give warfarin only. There is no other drug like warfarin. After 36 weeks, the problem is patient will undergo labor, right? So that's the reason I have to stop warfarin. And once again, I have to switch to heparin. I have to switch to heparin. Ideally, I have to use unfractionated heparin, but I can also switch over to low molecular heparin, anyone. But ideal and the best choice will be IV continuous drip of unfractionated heparin because it's short acting and I have a ready-made antidote that is protamine sulfate. So that's the reason this is the best choice. But you can use low molecular heparin like enoxaparin also. If you are using unfractionated heparin, when you have to stop it, you have to stop by approximately 6 hours, 4 to 6 hours prior to anticipated labor. In partogram, you're going to anticipate labor, right? So 4 to 6 hours prior to anticipated labor, you can stop unfractionated heparin. But if they ask about low molecular heparin, you have to stop 12 to 24 hours. 12 to 24 hours prior to anticipated labor. That's all. Because low molecular heparin is long acting. So you have to stop a little beforehand itself, 12 to 24 hours prior to anticipated labor. 4 to 6 hours for UFH and 12 to 24 hours for enoxaparin. And in the postpartum period, what you're going to do? In the postpartum period, by around 6 hours mark, you can start with warfarin and heparin together, some form of heparin. Typically, for this purpose, we're going to use only low molecular heparin together. Once the INR reaches target, once the INR reaches the target INR, that is 2 to 3 or 2.5 to 3.5, depending on the mechanical prosthetic valve, you're going to continue warfarin only and you're going to stop heparin. Continue with warfarin only and maintain the target INR. And warfarin is safe in lactation. Warfarin is considered to be extremely safe in lactation. So in postpartum women also, it's the best choice. But you cannot straight away start with warfarin alone. You have to bridge with heparin initially, because warfarin will take some 3 to 5 days to start acting. That's why once the INR reaches target, then you can stop heparin and continue with warfarin alone. So 5 to 12 weeks, look at the warf dose. If the INR is maintained with less than 5 milligram, continue with warfarin. If it's more than 5 milligram dose, then you have to switch over to enoxaparin. 12 to 36 weeks, no other option, only warfarin, nothing else. After 36 weeks, stop warfarin, switch over to heparin, ideally unfractionated heparin, but it can be enoxaparin also. In the postpartum period, you're going to restart warfarin along with heparin bridging. Once the INR reaches the target, you're going to stop heparin and switch over to warfarin alone. Do you understand this? What is the anticoagulation during pregnancy in the setting of mechanical prosthetic valve? So that's a very, very important algorithm. They're going to ask in exams for sure. Okay, all right. I think we have completed all the valvular heart disease, including anticoagulation, and prosthetic valves part. But maybe what I can do is I can just show some of the important valves. You can just notice here. This is the traditional cage ball valve, which is also called a Star Edwards valve. We don't use this valve anymore. This is the Medtronic Hall valve, otherwise called a single tilting disc valve. So then we have the bi-leaflet tilting disc valve. 2 leaflets will be there. So that's called a St. Jude valve. And here's an example of a porcine bioprocess called as Carpentier-Edwards valve. Any of these valves can be asked, but very commonly in exam, if at all they want us, they will ask about the bi-leaflet tilting disc, because this is very commonly used, otherwise called as St. Jude's valve. Bi-leaflet tilting disc. And that's it. I think everything is done. What all we have discussed, let us recap. I've told about rheumatic fever. I told about the treatment and prophylaxis and the clinical features, mitral stenosis. Then we have discussed about MR. Then we have discussed about AS. We have discussed about low flow AS also. We have discussed about AR. We have discussed about prosthetic valves and anticoagulation pregnancy also. And we have seen 2 clinical vignae. Hope this session was helpful to you. Okay. I don't know, like, how many of you have understood like whatever I've told, but I feel that I've tried my best to describe whatever I wanted to describe. And hopefully I've understood the echo part also, because echo part is actually the most toughest area to make an undergrad understand. So if you've understood the echo part, then I'm very happy. In fact, more than happy. And thank you very much. And this session will be available in the app. So don't worry about that. And I'm going to upload the annotated PDF in the app also. So you can have a look at those notes as well. And with that, I'm signing off. Thank you very much. Yeah, I'll try to do another session. No need to worry about that. But the next session will be probably on 18th of July. That's the next Tuesday. And it will be on congenital heart diseases. Okay, so that's something I have to do. Congenital heart diseases. Thank you very much. Bye-bye.